Okay, Lorena. Good morning. Lorena?
Nancy? Okay, go ahead.
Good morning. My name is Nancy Redeker, and I'm a professor here at Yale School of Nursing, and I have an appointment in the School of Medicine. I'm also the director of the Biobehavioral Laboratory here at Yale School of Nursing. I'd like to welcome you this morning to the 6th Annual Sleep and Symptom Symposium, co-sponsored by Yale School of Nursing, the School of Medicine Program in Sleep Medicine, and the section of Pulmonary Critical Care and Sleep Medicine. This symposium grew out of the ongoing and deepening interdisciplinary collaborations among faculty in these programs and our trainees, and from other departments at Yale and our highly successful NIH-funded Yale Center for Sleep Disturbance in Acute and Chronic Conditions, for which Dr. Yaggi and I were the principal investigators. We also have the benefit of the Yale School of Nursing Center for Biobehavioral Health Research. We are delighted at the many studies that have emerged from these efforts, and you will see excellent examples of these in later today in the posters. I would like to start this morning by thanking Lorena Fonte for her excellent organizational skills in getting us online for this meeting, and to thank Dean Kurth and Dr. Naftali Kaminsky, the section chief of Pulmonary Critical Care and Sleep Medicine, for giving their support for all our efforts. As Dr. Yaggi says, sleep is an inherently interdisciplinary field, and our collaborations are excellent examples of this. Our work spans the human lifespan from birth to old age and also across the trajectory of chronic conditions. Our studies include a focus on prevention of chronic health problems for people at risk, the role of sleep in chronobiology in chronic conditions such as heart failure, stroke, and substance abuse, and sleep among people with critical illness. Our efforts also increasingly address questions regarding health equity and sleep. All of our work is focused on ultimately developing, testing, and disseminating effective interventions to improve sleep and sleep-related outcomes. Most recently, we've also been engaged in a number of studies looking at the response to COVID, and some of that work is represented in the posters today. Dr. Yaggi will provide more information on our research program later in the early afternoon, and we hope you will view and engage with our posters and presenters. What I'd like to do now is to provide an overview of the day. After I finish speaking, Dr. Yaggi will introduce Dr. Sam Kuna from the University of Pennsylvania, who will be our first keynote speaker. Then at about 11:15, we will have a very brief break. And at 11:20, Dr. Teresa Ward from the University of Washington will give her presentation. Following that, and we've made a little bit of change in the agenda, Dr. Yaggi will give an overview of our sleep research programs here, and we will follow that with a poster viewing, which will go on for a little bit more than an hour. You've had an opportunity, I think, to see the posters on the website. Each poster viewer will have 2 Throughout the meeting, if you have comments, questions for the speakers, then each of the speakers will be followed by a moderated question and answer section. We ask you to use the Q&A question and answer link, not the chat link on the Zoom link to ask your questions. So I hope you have a wonderful day. I hope that next year we see you all face to face, but I hope you enjoy the day. Dr. Yaggi.
Nancy, thank you very much for that introduction and overview. This is, I think, one of our favorite times of the year to hear about all of the research that is going on at our center, sort of in preparation as a warm-up for the upcoming ATS meeting and the sleep meeting. And we're going to start off the day with 2 phenomenal sleep investigators. It's my pleasure to introduce Dr. Sam Kuna. Sam is a friend and is a professor of medicine at the University of Pennsylvania and chief of the sleep medicine section at the Crescenz VA Medical Center in Philadelphia. And his research has focused on developing ambulatory and telemedicine-based approaches to the diagnosis and treatment of adults with obstructive sleep apnea. And Sam has indeed been a leader in performing studies and trials using home sleep apnea testing and auto-titrating sleep apnea. And his clinical trials in this domain really have led to changes in how we practice sleep medicine. He's also a leader in VA-based sleep medicine and runs the VA Office of Connected Care's Remote Veterans Apnea Management Platform, the REVAMP project, which is now distributed across VA centers across the country. His talk today is entitled Sleep Apnea After the Pandemic, the New Normal. Sam, thank you very much for joining us today.
Thanks very much, Klar. It's a pleasure to be here, and I'm delighted to participate in your symposium. I'm going to share my screen. Let me see how I do this. This one. And I hope now that you can see my screen.
Not yet, Sam. Not yet. Let's try that. Are you a share screen at the bottom? There you go.
There we go. All right.
Perfect.
Very good. Thank you very much. Let me get this up. So the title of my talk is Sleep Medicine After the Pandemic, the New Normal. And I know throughout this devastating time of the pandemic that probably all of us have adapted strategies to cope with the stress. And one of the strategies that I adopted was to go back to school. And I want to thank Yale Opportunity for the opportunity to view the open Yale courses, which are free, on the website. And over the past year, I have done the course of Professor Freeman on American Revolution, Professor Kleiner on Roman architecture, and Professor Kagan on ancient Greek history. And as you can see by my selection of the courses, I'm very interested in history, and because it helps us to not only know about the past, but also to anticipate what's going to be coming in the future. And I don't know if I got this quote from Socrates from Dr. Kagan or from Dr. Gender in her course of philosophy, but the secret of change is to focus all of your energy, not on fighting the old, but on building the new. And this certainly can apply to the evolution of sleep medicine over the past decade, particularly within the last year that we've been fighting the pandemic. What I'd like to do in this presentation is to review with you some of those developments that have evolved and help us to understand perhaps where things are going to be going. I'd first like to share with you the pre-pandemic ambulatory management clinic pathway that we developed here at the Philadelphia VA Medical Center, and then to show how that accelerated into a complete telemedicine pathway that I think was widely distributed across the United States. I want to share with you some of the studies that we've done in an attempt to expand the application of home sleep apnea testing to patients with comorbid disease. And I'd then like to review with you our experience with REVAMP, which I think was a very interesting illustration of how websites can be used and the challenges that exist in implementing them in a widespread network. And finally, I want to tell you about the very innovative hub-spoke model that has been developed by the VA Office of Rural Health Program to create a national sleep network. So the initial study that I'd like to share with you is the Veteran Sleep Apnea Treatment Trial, So this dates back over 10 years ago, at a time when polysomnography was still the leading diagnostic test for people with obstructive sleep apnea. And what we did in this study was to randomize people to either the in-laboratory testing with polysomnography, including CPAP titration, and the other group was assigned to home sleep apnea testing, a home auto-PAP titration for about 1 week. And at that time, we were still using fixed CPAP, and so they came back after a week and we switched them over to fixed CPAP. Now, the outcomes of this study were not to do a head-to-head comparison of AHI, of home sleep testing versus in-lab polysomnography, but rather to look at the outcomes of these clinical management pathways. Our main outcome was the functional outcome of sleep questionnaire. We also looked at CPAP adherence between the two groups and the medical cost. And what we found was that there was a significant improvement within both groups, in-lab testing and home testing, in the FAHA score. But the improvement in the home testing group was not clinically inferior to that of the in-lab tested group. In addition, we found that CPAP adherence in the home tested group was not clinically inferior to that of the in-lab participants' adherence, and that the cost of the home testing pathway was $500 less per patient than the in-laboratory pathway. So this test helped to unlink the patient from diagnostic testing and CPAP titration within the sleep center. And it led us to develop an ambulatory management pathway. Patients were still coming into the sleep center for their initial evaluation, but they were going home from that clinic visit with a portable monitor, having received in-person instructions. We then switched to the auto CPAP as our default treatment, and we had the data chip or wireless PAP data transmission, and then patients were coming back in for their in-person follow-up assessment. Well, the VA has always been interested in telemedicine, even prior to the pandemic. The US Congress had mandated to the VA that it reach out to veterans in rural areas. And many of the veterans who are coming back from Iraq and Afghanistan wars are relocating in rural areas. And the VA has an obligation to provide access to their health care. So this is VA Secretary David Shulkin, who is demonstrating the telemedicine equipment to the president at the White House. I always look at this picture and I think, well, I remember the section that used to run in the Sunday magazine of the New York Times. I don't know if it's still there, but they would show a picture and then you would have to write a caption to that picture. And I won't provide my caption, but I think Dr. Shulkin's Cheshire cat-like smile and his hands in his pocket would generate many different comments. But this was a very important initiative of the VA to establish telemedicine across its entire national network. And so equipment was put into every VA facility, and practitioners were able to access that web platform through their personal computers and their offices with webcams attached to it. So it became very widely used across the VA. And with that, we were able to modify our ambulatory management pathway so that now the patients who are going to VA primary care clinics that were supported by the Philadelphia VA, and patients who are going to our sister VA medical center in Coatesville, Pennsylvania, were able to have video teleconferencing by the providers in Philadelphia to their respective facilities. So they did not have to come in for their in-person visit. They did not have to come in for their follow-up visit. So now we had an ambulatory management pathway where the patients could be diagnosed, treated and managed without having to come into a sleep center. We had respiratory therapists who would go out to the VA clinics and respiratory therapists at the Coatesville VA who would help out with the CPAP setup. So the question that we had was, is this something that the patients like, and are we going to have similar outcomes with this ambulatory management pathway compared to the in-person? And Barry Fields, who was then a Penn Sleep Fellow working at the VA, did a randomized control trial where he compared the in-person management, which included home sleep testing and auto CPAP, to telemedicine management, where the patient got a video teleconference at their local facility, home sleep testing, where they were just given a brochure. On the other arm, they were given in-person instructions. Here in the telemedicine arm, they were just given a brochure and said, go home and do this study. And then again, they got auto CPAP treatment. We had follow-ups at 1 month and 3 months. What Barry found is that CPAP adherence across the between the two groups was similar. You can see our adherence in the veteran population is terrible, but there was no difference between the telemedicine and in-person groups. In addition, Barry did an assessment of patient satisfaction with the telemedicine management, looking at 2 validated instruments, the Working Alliance Index and the Client Satisfaction Questionnaire, where he found no difference between the two groups. And he also did structured interviews looking at patient satisfaction. And by and large, the patients all appreciated the fact that the telemedicine was so convenient for them. Some preferred to have the in-person, but they felt that the convenience overrode the face-to-face encounter. So we felt quite comfortable in using this telemedicine pathway in our patients. Well, that worked within the VA system, which was a health maintenance organization, but hard to expect that the private sector would take this up. It was a situation very similar to what we encountered with portable monitor testing. If you can't charge for the test and get the same charge that you're getting with the polysomnogram, why should you switch over to a portable monitor? A similar situation is what we were confronted with in pre-pandemic with telemedicine. It did not pay as much as the in-person visit, and there were restrictions for delivering care across state lines if you did not have a medical license in both of those states. All of that changed with the advent of the COVID pandemic. The barriers to using this in the private sector were quickly removed by CMS and major insurance carriers, so that telemedicine now had a reimbursement on par with that of in-person visits. And providers were able to deliver that care across state lines. The problem that we faced at the Philadelphia VA is that, like everywhere else, all of the clinics were closed. So CVT was out, no video conferencing from one facility to another. However, we were able, as most, I think, sites across the nation were able to do, is to quickly shift over to using Doximity, and then VA subsequently developed the VA Video Connect ability to communicate with the patients by means of their mobile devices. So veterans are in a lower socioeconomic status. Many do not have PCs, many do not have laptops, but they all have smartphones. And so we were able to continue our ambulatory management, this time using the mobile device for the in-person assessment, for the initial assessment and the follow-up assessment. So the COVID-19 telemedicine pathway became a video conference or backup as phone. The home sleep test was now being totally done by mail. So we would mail out the monitors, the veterans would have the instructions, they would mail them back. The video, the auto CPAP continued to be used as a treatment. This did not work so well. So I think this is one where we're really looking forward to getting back to the in-person setup. The DME company that we're contracted with was unwilling to go into the home during the surge of the pandemic. And so they would do a drop ship and we would schedule a video teleconference to give instructions. And we used a multi-fit mask so the patients had different mask sizes that they could try. I don't know of any studies that have compared this approach to the in-person approach. It'd be very interesting to see that, but I'm also very anxious to get back to an in-person setup for auto CPAP. The follow-up in this pathway was again by video conferencing or by phone. So this is how we've been operating. We're very slowly shifting back over now to some in-person, but still 90% plus of patients are going through this telemedicine pathway. Unfortunately, we have some evidence from the Sleep and Breathing Consortium in Spain comparing the in-person pathway with this telemedicine pathway. On the in-person pathway, they did a diagnostic testing with either PSG, home sleep test, or in-lab portable monitor. And there was an in-person clinic visit with the physician. Curiously, they brought the patients in for a CPAP titration into the laboratory, and then they started them on a fixed CPAP pressure. In contrast, in the telemedicine pathway, there were 3 nights of home sleep testing, phone or video conference with the MD. Auto CPAP was started at home, and there was wireless transmission of the data. Follow-up was in-person with the in-person pathway. It was by phone or video conference with the telemedicine. At the 3-month endpoint, they found that mean CPAP adherence between the 2 arms was the same, so there was no clinically significant difference. And they also looked at functional outcomes. They actually found a greater improvement in the visual analog scale on the Euroqual, slight difference in this social Quebec satisfaction questionnaire, but the Quebec sleep questionnaire, no significant functional questionnaire, no significant difference. So again, nice evidence that the telemedicine pathway does work in giving us similar outcomes as the in-person pathway. And I want to, although I'm a pulmonologist and most of my thoughts are concentrated on management of obstructive sleep apnea, I do want to give an acknowledgement that this shift over to telemedicine has also worked extremely well for psychologists who are helping people with chronic insomnia and the delivery of CBTI by video conferencing or phone. And this is a small study. It was a randomized trial that was done by Phil Gehrman at Penn, where they randomized people with chronic insomnia into either a waitlist group or a group that received the video conferencing either by video teleconferencing or in-person delivery of the CBTI. At the 2-week point, they found that there was, this is follow-up after the 6 to 8 sessions of CBTI. They found that there was a significant improvement in the insomnia severity index score compared to the waitlist group. And at the 3-month endpoint, there was no clinically significant difference in the improvement in the insomnia severity index, comparing the telemedicine to the in-person delivery of CBTI. So I've always been a strong advocate of telemedicine, even before the pandemic. Has great advantages. Its convenience. It reduces patient time off from work, so they don't have to take off a half a day in order to get in to see the doctor. It reduces the expense of travel, not only for the patient, but for the VA, because the VA pays many of its patients who have scheduled appointments for their travel time. And it was very popular among the staff because it allowed them to telework. They had kids at home and they didn't want to come in. And so they were able to continue their work. We got everybody VA laptops. They were able to connect to the electronic medical record, and that worked extremely well. The telemedicine also offers increased access of care. The staff started complaining actually that their clinics were too busy doing the telemedicine because they were reaching everybody. They no longer had the 20% no-show rate of the in-person visits. And so they wanted their clinic profiles reduced so that they could get all of their work done. The other major advantage in the VA is that we have a lot of disabled patients. And as you'll see, many rural patients that have difficulty getting into a sleep center. And we were able to reach those people. And there's the decreased cost. But as I immersed myself in telemedicine without any in-person encounters, I also became aware of the several disadvantages of telemedicine. I do feel that it limited my ability to form an interpersonal relationship with the patient. And I'm looking forward to going back to certainly the initial evaluation being face-to-face. And that will allow me to do a physical exam, which I really miss. As a pulmonologist, I don't listen to their lungs, but I do a very careful exam of the upper airway, including the nasal passage. I feel that the telemedicine has compromised our ability to train staff and fellows. We had a number of new staff entering into our team over the past year, and it's been very difficult to get them up to speed using just the telemedicine applications. And I think the fellows have missed the 360 experience. They're interacting with the physicians, but they are not bumping into the clerks, the therapists, the physician assistants, the nurse practitioners to see how a sleep center actually operates. And we need to get them back into the sleep center so that they can learn that experience as well as how to manage an individual patient. The other problem that I've encountered and other people in the VA have encountered in our sleep center is the patient's casual approach to remote care. So you call the patient at 9 o'clock in the morning and they say, "Oh, doctor, I can't do it now. Can you call me back this afternoon?" No, I have a clinic this afternoon. I have scheduled appointments. You call the patient at 10 o'clock and they say, "Oh, doctor, can you call me later? I'm driving in the car." Or you call the patient at 11 and they say, "Oh, doctor, can you call me back in 5 minutes?" Well, I wonder what they're doing. It only takes them 5 minutes for me to get back to them. But they just they do it on the fly. And they don't take it as seriously as they would if they're coming in to a visit and they're carving out time within their busy activities of daily living and obligations in order to take care of their medical problems. One of the things that we wanted to do in order to expand the scope of home sleep testing was to allow it to be used in patients with comorbid diseases. So we have a great deal of flexibility as practitioners within the VA to treat patients without the overview of private carrier insurance companies. But we have a lot of patients with COPD and chronic heart failure. And current clinical practice guidelines dictate that these people should not have home sleep testing, that they should be brought into the laboratory for a polysomnogram. Now, the VA does expect its practitioners to follow clinical practice guidelines. And so what we wanted to do was expand the sleep testing to this patient population. And the design that we used was to take patients who were referred to the sleep center for diagnosis of sleep apnea. They first performed the home testing. They had no previous experience with sleep testing, and we wanted to see if they could do it. And then we brought them back and they did an overnight polysomnogram with a simultaneous portable monitor test. So that the simultaneous recording would then controlled for differences in night, where we know that there's great variability, even in the polysomnogram, in results from one night to another. And it also controlled for differences in environment. So with the simultaneous in-lab PSG and portable monitor, we're looking more at the technical differences between the two diagnostic tests. For the group with COPD, we had 90 patients, and we did this study in collaboration with investigators at the Peking University. You can see we had relatively severe people with COPD. The FEV1 was 1.57, the FEV1 over FVC, 53%. And when we compared the home testing with the in-lab testing, and the in-lab portable monitor with the polysomnogram, and looked at the different cutoffs for diagnosis of sleep apnea, you can see that we had very good sensitivity, specificity, and positive and negative predictive ratios. And these measures were certainly higher within the simultaneous comparison, as would be expected without the differences in night-to-night variability and environment. For the group with chronic heart failure, we again did this in collaboration with Peking University. We had 84 patients. We tried to enrich our sample with people with more severe chronic heart failure in order to try to capture people who are more likely to have central sleep apnea and Cheyne-Stokes breathing, problems that you do not want to miss with your diagnostic tests. So we had a left ventricular ejection fraction of about 40% in our group, and 50% of the people, 71% of the people had an ejection fraction less than 50%. And what we found here is showing the people without sleep apnea on the three tests, the people with mild sleep apnea, moderate, and severe. And you can see quite good discrimination of the people with and without sleep apnea on the portable monitor testing, either in lab or at home. In addition, the portable monitor is quite good at picking up the central sleep apnea in these patients. The particular portable monitor that we used was employing respiratory inductance plethysmography as a way of detecting chest wall movements. In addition, we scored the studies for Cheyne-Stokes breathing, another feature in people with chronic heart failure that you do not want to miss. And we found, again, a very good agreement between the polysomnogram and the portable monitor, either at home or in the laboratory. And this graph shows the simultaneous recordings of those two. The other key feature of an ambulatory test pathway is the auto CPAP use for treatment at home, and that the manufacturers have provided websites where the data from the patient's home machine can be wirelessly transmitted to the manufacturer's server, the proverbial cloud, and the manufacturer then shares that information with the practitioner, but also provides a patient website where the patients can view their results. And we asked the question, what difference does that make for the patient? Does this access to their data help them to improve their CPAP adherence? We conducted a randomized controlled trial where people who had been diagnosed with moderate to severe sleep apnea were randomized to one of three groups. There was a usual care group that did not have access to their web information, their CPAP information on the website. There was a web access group that every day they could go in and they could see how much they were using the treatment. And there was another group that we gave them web access again, but that we also gave them a financial incentive. So that in the first week, if they use their treatment at least 4 hours a day, then each day that they would get a $30 reimbursement. So in the first week, if they used it every day, they could get, for 4 hours, they could get a total of $210. And we follow these people over a 3-month period to look at differences in their CPAP adherence. And what we found is shown here in weekly average use of their CPAP. And you can see that even in the first week, there is a clear separation of 1 hour between the two groups that had access to their web information versus the usual care group. And the fascinating thing was that this pattern that was established in the first week is maintained throughout the 3-month period, despite the fact that in all groups, there was a gradual decline in the CPAP adherence. So you can impact their use with initial upfront interventions, but that something needs to be done during the course of the treatment to help patients to sustain their CPAP adherence. We had the ability to track the percentage of people who were going into the website every day who had web access. And what you see here is that in the first week, the people who were getting the financial incentive were quite excited. They were going into that website much more frequently than the people who did not just had the web access. But after that first week, there was a precipitous decline in use of that website in both groups. So by the end of 3 months, only 10% of people were going in and checking their data. And as we see more and more apps coming out to help people to obtain information about their CPAP treatment, as well as other medical treatments, I think we have to design these applications in order to keep them engaged within their medical care, and not just to go to something very novel in the beginning and then move on to the next novel website app that they happen to come across. That experience with using a website to help people with their medical care led to the concept of developing a web-based platform to acquire information about patients' symptoms and outcomes. So we wanted to develop a website where we could get a standardized history and sleep study results, merge that with the wireless CPAP transmission, hopefully connect that website to the electronic medical record to look at patient-centered outcomes. And so Katie Sarmiento, who's currently at the San Francisco VA, Carl Stepnowski at the San Diego VA, and myself applied to the VA Innovation Center to develop a website which subsequently was called REVAMP, Remote Veteran Apnea Management Portal. REVAMP has a veteran-facing and patient and practitioner-facing platform. Veterans can go into the website and complete questionnaires, including validated questionnaires. We have the Epworth, the FOSC, the SF-12, the depression questionnaire. We had agreements with the PAP manufacturers to send their wireless data to the website so the patients could view it. We had frequently asked questions and videos for education, and a secure messaging system where the patients could communicate with their providers. The practitioners were able to see all of this information that was being obtained from the patients, and we have a auto export function where all of this information can be exported out to a templated progress note that the practitioner could copy and paste into the electronic medical record, a huge time saver for the practitioner. We launched REVAMP in 2008. We enrolled sites across the VA in waves. By the February of 2020, the start of the pandemic, there were about 50 VA medical centers who had access to REVAMP. And by February of 2020, we had 12,000 people who had accounts created, but only 37% of the veterans had actually logged on. The logon required a special access code similar to my chart that you use at Yale that would allow them to get into this website, which was behind the firewall. And by February 2020, we had 10,000 people on whom we were getting PAP data on REVAMP, but only 25% of the people had actually checked their CPAP data. So the VA was and we were quite disappointed with this, that 12,000, 10,000 people it sounds pretty large for clinical trials that I do, but there are hundreds of thousands of people in the VA who are being diagnosed and treated with sleep apnea. And so the uptake by the patients and practitioners was disappointing. And so there were what we learned from REVAMP is that there are a number of barriers to the implementation and acceptance of these web-based platforms. The one is that we had personal information on the website. It had to be within the VA firewall, and that required this special premium account in order for veterans to get in. It wasn't as easy as the veterans using the websites that the manufacturers have developed for seeing their CPAP information. It was also very difficult in getting VA approval and getting through the VA regulations to develop the platform. The VA is extremely concerned, as it should be, with privacy and security. And making changes on the website, I liken to crawling through the 12 stations of the cross and trying to get approval from every single regulatory agency in order to make even minor changes. The other major problem that we encountered was that the platform was not connected to the VA electronic medical record. We wanted to do this, but again, it was technically very, very difficult. And it did require double entry by the clinicians. So whatever you do, never ask a clinician to do more work because they're just not going to comply with that. And the other problem is that even if they did more work, they didn't get workload credit for it. So we didn't have a way of communicating between REVAMP and the electronic medical record. And that was a major flaw. We certainly encountered funding challenges because the VA prefers to buy things rather than to make them. So it likes to contract out rather than to make something de novo. All of that comes to the fact that the VA has decided to sunset REVAMP and will probably be closing it down sometime later this year. Enormous effort went into creating this website. I learned a great deal about web-based platforms in it, so it wasn't time wasted. And as John Denver told us, you hold on tightly, but you let go lightly. You engage with your enterprise, but if it's not working, let it go and move on. And what the VA has decided to do was to contract out with a commercial cloud-based platform called Somnoware, and it's in the process of implementing this nationally. The Somnoware does not have a patient-facing platform, but it does communicate with the electronic medical record, and it's a one-stop, all-purpose function, including scheduling, scoring of sleep tests. So all of the recordings will be going up to the cloud for scoring. The interpretation report is generated on the cloud. Then it comes down to the electronic medical record, and the ordering of the CPAP is also done on the Somnoware website. And I show this because this is the general direction that manufacturers are going, including the manufacturers for polysomnography, home sleep testing, and these patient management platforms. They want everything to go up to the cloud so that they have the data. And I think with the manufacturers of the diagnostic testing equipment, they want that data and the manual scoring in order to develop the algorithms for auto scoring of these recordings. Well, undeterred by REVAMP, what we've moved on to is more engagement within the Office of Rural Health Telesleep program, which has allowed us to expand this hub-spoke model of delivering care. So the sleep center then can reach out to primary care clinics, sites with no sleep program, patients in rural areas, and disabled patients using physicians and non-MD practitioners, nurse practitioners, respiratory therapists, doing this telemedicine pathway, video teleconferencing, home sleep testing, auto CPAP, and the REVAMP while it's still around. The Office of Rural Health is funding about 15 VA medical centers to serve as hubs and deliver care to veterans in rural areas. Philadelphia is one of those hubs. There aren't many rural areas around Philadelphia, so we had to go out pretty far in order to find veterans in rural areas. But we're delivering care to veterans in upstate New York, Canandaigua and Bath VA Medical Center, up the Upper Peninsula of Michigan, the Iron Mountain VA, and St. Cloud VA Medical Center in Minnesota. So the secret of change is to focus all of your energy not on fighting the old, but on building the new. And I think we can look at the evolution that has occurred over the, certainly over the past year, and see that we're probably heading towards a hybrid model of delivery of care. That I think the in-person visits will resume for the physical exam, for the interpersonal connection. Hopefully the insurance carriers will not re-erect the barriers that they have taken down, and will allow us to continue to do the video teleconferencing without so that it's financially viable. I think we will retain the telemedicine for delivery of CBTI and obstructive sleep apnea, particularly because it increases access. It will allow people to continue telework. I think it's been very popular among our staff, and a lot of people are interested in doing some in-person work at the medical center, but also doing some telework. And the decreased cost, I think, will incentivize the insurance companies to start mandating more telemedicine. I think we'll see a reliance on cloud-based platforms that are integrated with the electronic health record, and we'll be using that for sleep testing, scoring, collection of questionnaires and patient information. And this will help us to develop high-performance sleep disorder networks to deliver cost-effective care. In addition, with these high-performance sleep disorder networks, we'll have the large data sets that we will be able to ask important questions that we have not been able to answer effectively to convince healthcare carriers that we're doing a good job and that CPAP treatment is important. I think we'll see increased reliance on non-physician sleep specialists and primary care providers, perhaps to deliver routine care to patients with OSA and chronic insomnia. And I think we all have to keep our eye on the likely developments of new technologies that are going to completely disrupt what we currently have established. The technology has always outperformed, outled our clinical practice, and we always seem to be trying to catch up. Well, as Paolo Cielo commented, he's the author of The Alchemist, and when you can't go back, you have to worry only about the best way of moving forward. I think the road ahead has bumps and curves. There are clouds on the horizon, but I think we've learned a lot during the pandemic that will provide us with new tools that will allow us to provide more effective and efficient care to our patients moving forward. Thank you very much. I greatly appreciate the opportunity to participate in your symposium.
Sam, that was absolutely wonderful. Thank you very much for that thoughtful presentation. And I think what I'm most struck by is this history of really excellent scholarship that not only directly informs clinical care, but has also allowed us to adapt as a field to changing healthcare environments. And it really, it sort of has built so nicely over the years. And in fact, at our center, our clinical centers at VA Connecticut and our Yale New Haven Hospital Sleep Medicine Center, we were really able to continue our clinical services straight through the pandemic, largely because of the home sleep apnea testing program. We had shut down, the lab largely, but we're able to keep the clinical program really moving. And it occurred to me, what if we hadn't done that prior? What if the pandemic had actually hit prior to our ability to embrace these ambulatory care pathways? So just really amazing work there. There are a few questions, and I wanted to start out by asking you, given the sort of wider reach that we have now as centers through telehealth platforms, and this is very beautifully demonstrated on the VA side towards the end of your talk, this sort of hub and spoke model. Do you think this is going to lead to, on the private side, so on the non-VA side, to more of a consolidation of sleep services being provided through main centers, or do you think those main centers really are what we should be sort of emulating the VA and actively reaching out to more rural areas to bring folks into our clinical programs? How do you see this on the non-VA side shaping up?
I think the hub spoke model has a lot of opportunity. In one sense, it helps to address the lack of providers that we have. So we're not training, it's clear, we're not training enough people in sleep medicine to take care of all the people that have sleep disorders. We're not training enough psychologists for doing CPTI. We're not training enough people to handle people with obstructive sleep apnea. So how are we going to compensate for that? And one way is perhaps to do this hub spoke model, where you don't have to plant a sleep specialist or a psychology expert in each medical facility, but that you can provide that specialty training from a hub site, reaching out to the patients at these other areas. And it doesn't have to be just to rural areas. It can be to local hospitals that don't have a sleep specialist and are looking for additional services that they can offer to patients so that they'll come to their local hospital. It's a great advertisement for their local hospitals to say, oh, you can get your sleep services here. So I think that's a very important aspect of it. Whether or not it takes off in the private sector is again going to be driven financially. It's whether or not you can make money in order to pay the rent, pay the salaries, and you don't have to be dependent, as I am, on Congress passing a budget every year that will guarantee us a salary.
Right. Excellent point. Yeah, interesting times for sure. So there were a couple of, I think, very important questions. Dr. Krieger had two questions. So the first was, what device was used for home sleep testing in Beijing that you mentioned?
So we both used the Knox T3. So this is a type 3 portable monitor. It records nasal pressure, rib cage and abdominal movement, and pulse oximetry for heart rate and oxygen saturation, as well as position. So typical respiratory measurements, signals on a type 3 portable monitor.
Okay, very good. And his follow-up question is there a role for more consumer devices, Fitbit, etc., to diagnose and manage obstructive sleep apnea?
Yeah, so that's a difficult question to answer. I have not seen data at this point which validates their use in widespread application. Patients are constantly coming in with their Fitbit reports, and they say, "Oh, look, doctor, look at all the REM sleep I'm having." It's like, yeah, but the study showed it doesn't. It's not working right. So, but I think that's where the field is going. I mean, the revolution that we're seeing in technology is still accelerating at a very rapid pace, and we're going to be seeing sensors that we didn't even dream of coming out, and they will be validated. And those are the future directions in technology that we have to keep looking at. I mean, I'm heavily invested in home sleep testing, and we've got 100 or more of portable sleep monitors that we're sending out every day, and the VA is invested heavily in that equipment. If someone comes out tomorrow and says, "Oh, you don't have to use this equipment. You can use this thing that you can just patch on their chest and it's fine," it totally disrupts what we're doing, and we've got to rapidly change. So keep an eye on these technologies that are coming out.
Yeah, I 100% agree with you. I mean, we now have watches that are monitoring oxygen saturation, but I also agree with the comment that I think in terms of their current role, it seems like what they have been really helpful in doing is actually maybe precipitating a patient coming and seeing us. They actually are monitoring their sleep. They're seeing how disrupted their sleep is, and that's triggering a visit to a sleep medicine specialist. So although that data isn't valid, at least it got them in our doors so that we can better evaluate the patients. Dora Wishek has asked, what are the biggest barriers or reasons to not complying with or sustaining CPAP treatment? Is that different in different age groups or veteran cohorts, such as Vietnam versus post 9/11 era veterans?
Yeah, so that if I had the answer to that question, I would be very, very happy, because I would have CPAP adherence that was a lot better than what I'm achieving. I think we've been very good at the upfront loading of CPAP education, patient support, but in helping patients to overcome the initial barriers to CPAP treatment. We have not been as successful in maintaining that treatment long term. And regardless of what study you look at in these large studies such as the SAVE trial or any other of the randomized controlled trials looking at long-term CPAP use, there is a gradual decline no matter what you do. So even in research studies where patients are more likely to use it than in a community setting, a community population, we're still seeing this very disappointing use of CPAP in the long term. Certainly a challenge that has to be addressed if we're going to convince people that there are long-term benefits of CPAP treatment in terms of stroke or cardiovascular, cardiac improvements. We have not been successful in making that case. So there are many approaches that are now being tested to try to maintain that adherence. Coaches, for example, to contact the patients, text messaging to remind the patients to use their treatment or congratulate them that they're using their treatment. All of these things are being tested in terms of their impact on adherence and whether or not it's feasible in doing it, because it's more work. I know at Penn, Amy Sawyer is very interested in automated approaches to be able to do this so that it doesn't require more workload on the terms on the practitioner to invest that time, because again, there's no reimbursement for that.
Right. Yeah, I was really struck by that graph. I mean, I've seen the graphs over and over again, but I think the data that you shared, this continuing decline, the interest in patients in REVAMP on the website up front, that sort of declined over time as well. And I think stating very clearly that we don't just need, I think we've been hyper-focused as a field on the very early adherence period, because I think we associate that with predicting longer term adherence. But there is a real need, I think, for some sort of sustained effort. And I wonder how much of that decline in CPAP adherence are patients totally dropping out of therapy, thus driving the overall adherence down, or reducing their own hours of use per night. The interventions, I think, would be different for those different scenarios.
I don't have the answer to that. It's a very, very important point.
Right. Yori Wang has asked, I think, and this is in relation to the Somnoware platform that you mentioned being implemented across the VA. I know a number of other programs are using this now outside of the VA. So with respect to the Somnoware, is there a specific mobile app developed for this sort of cloud-based technology platforms?
Yeah, so I don't know the answer to that question. That's a very important. Again, this is only practitioner-based, so the patients cannot access Somnoware. Somnoware does collect patient questionnaires, but it does it on a separate platform. It's like a SurveyMonkey type of platform, and then it takes those responses and brings it into its own parent website. So I don't, I'm not aware that Somnoware works on a mobile platform. I think it may, but it certainly will have patient information on it. So I think at least within the VA, it's going to require that you be on the VA network.
Right. Right. I think you're absolutely right. It is designed for centers. It is designed for clinicians. I know it pulls in data from the adherence platforms from both ResMed and Respironics that allow us to get that data. And there are different platforms that are available to patients to monitor their CPAP adherence, MyAir, and forth. But yeah, I think you're absolutely right. It really is for the center, for the providers. But I know they are reaching out and developing portals, and portals exist to better communicate with DME companies. So it does make you wonder whether there will be platforms or portals in the future with direct patient communication. That's an interesting question. Another question by Dora Wischek. Also wonder if there are any studies looking at the impact of CPAP use in decreasing the incidence of respiratory infections. That may come very timely in the time of COVID-19. Are you aware of it? This wasn't really the focus of your talk, obviously, but.
I'm not aware of any. We certainly, during the pandemic, went through a lot of discussions about the use of CPAP in people who did have infections with the COVID, and whether or not we were spreading them by having them on this positive airway pressure machine, which was spewing air out into the room through the mask. And so that was one of the reasons that in-lab testing was quickly stopped. And even patients coming into the hospital who were on CPAP at home, unless you had a negative pressure room, they were not continued on their CPAP treatment for fear that it would spread the infection. So I'm not sure about, I don't know of any data showing that CPAP prevents infection, but certainly with the COVID-19 infection, CPAP potentially could spread it. And we did recommend to patients at home that if they develop the COVID vaccine, they should do a lockdown in a bedroom and not expose themselves to their families. They could use the CPAP in the bedroom.
Excellent response. I agree, and that required a lot of communication with patients at the very beginning of this pandemic. I think we did the same sort of reach out, and in fact, our own Dr. Krieger, together with Robert Thomas at Beth Israel, developed an expiratory port for ambulatory CPAP devices for home use to try to filter out. It was quite innovative. And I think that the hospital BiPAP devices, CPAP devices have built-in filters into them, but not the ones for home use. And so that was quite an issue. Well, Sam, thank you so much. That was really a really thoughtful, wonderful presentation, a great way to start out this symposium for us today. And we appreciate you also taking the time to answer the questions, the various questions that came up. So thank you for your participation. I think what we're going to do now is take about a 7 to 8 minute break and resume actually a little bit earlier at 11:15, which may give us a little bit more time towards the end of the conference. So if people want to take a coffee break, we'll go ahead and return at 11:15 a.m. All right, thank you.
Had a really short but happy break. It's my honor to introduce our next speaker, Dr. Teresa Ward from the University of Washington. Dr. Ward's program of research has focused on sleep health, symptom science, and health outcomes in preschool and school-age children with and without chronic health conditions. She is currently a professor and chair in child, family, and population health nursing at the University of Washington School of Nursing and co-director of the Center for Innovation in Sleep Health Management. I've been delighted to know her over these past 3 years through the Sleep Society Nurses Research Group and through the NINR Center Directors, and so happy to see the development of research, her program of research. Dr. Ward earned her BSN from Allentine College of St. Francis de Sales in Center Valley, Pennsylvania. She went on to earn her MSN from Drexel in Philadelphia and her PhD in nursing from the University of California at San Francisco. She also did a 2-year postdoctoral fellowship at the University of Washington School of Nursing. Prior to that, she practiced as a nurse practitioner in a pediatric sleep center at the Children's Hospital of Philadelphia for several years. So we have a lot of Philadelphia connections today. Welcome, Dr. Ward.
Thank you, Nancy. Appreciate the introduction and the invitation today. Let's see. Can you all see my slides? Well, I'm flattered to be here and really want to extend a big thank you to the Yale School of Nursing community and School of Medicine community. And hopefully someday I'll be able to visit Yale. I haven't had a chance to visit in person. So today I'm going to chat a bit about sleep health and M health interventions in pediatric chronic conditions. Something near and dear to my heart, hopefully yours. And then hopefully by the end of this presentation, we'll describe common sleep problems, identify current gaps in the pediatric sleep interventions, talk a bit about the current M health pediatric sleep interventions, which are really in its infancy, early development. And the importance of community-based participatory approaches and when we're thinking about the use of M health and developing interventions, and then some recommendations to think about. In terms of conflicts of interest, I have none. I'm very grateful for the National Institute of Nursing Research for funding our research. We have a P30 Center for Innovation in Sleep Self-Management, otherwise known as SISM. And I'll chat a bit about those projects today. And then a few other spin-off grants from our center grant. So why focus on sleep? For those of you who have infants, that picture on the left, you can resonate. And those of you that have adolescents, that picture on the bottom right might resonate with you. Sleep kind of bleeds through every portion of our life, not only individually, but also how we interact with our caregivers and peers, teachers, and so forth. Pediatric sleep problems, they're a major public health concern. The prevalences here are quite high, and over the last decade, they've remained high. Insomnia is a common problem, particularly for school-age children and adolescents. So difficulty falling asleep and maintaining sleep tend to be more common versus the early morning awakenings. And then the consequences of sleep, which you well know, they're often comorbid with acute and chronic conditions, symptoms of pain, fatigue, anxiety, depression, as well as some developmental issues we need to think about in children in terms of puberty, high school, early school start times, and this balance in terms of their hobbies, school, and sleep all kind of interact and have particularly consequences in terms of important health outcomes, whether that's health-related quality of life, our mental health, obesity, and inflammation. So I want to spend a little bit of time on cognitive behavioral therapy for insomnia, or CBTI. This is the first line of therapy for behavioral problems in children. And so we're targeting both the behavioral and cognitive components. And unlike adults, in children, we've had few randomized controlled trials in school-age children and adolescents. To date, there's been 6 that I know of. There was a recent meta-analysis, which I'll share with you in a moment. And of the 6 randomized controlled trials, 4 of those have been done in Australia, 1 in the US, and 1 in the Netherlands. And they primarily focus on adolescents. Face-to-face and telephone sessions are commonly used, and the number of sessions can vary from 2 to 6. So this was a recent review, systematic review by Oslin and colleagues. And you could see here of these 6 interventions, there were variability in terms of the types of components that were involved in the CBT. Sleep education, hygiene being the most common, but much more variability with relaxation techniques, stimulus control, and bedtime fading, and cognitive therapy. And of the 6 interventions, 2 of them really focused on kids who had anxiety and sleep problems, and another one focusing on kids who had sleep problems and depression. These randomized controlled trials looked at between group differences, and the children were between 7 and 20 years of age. And so just a few key findings. There were small to moderate effect sizes for total sleep time post-intervention, but over time, meaning 4 to 8 weeks later, post-intervention, the effect sizes went away for total sleep time. Whereas for sleep onset latency and wake after sleep onset, there were bigger effect sizes both immediately after the intervention and then 2 months later, anywhere from 0.4 to 0.5 in terms of effect size. These studies measured sleep with both actigraphy and parent self-report. So, you could see here that we have some work to do in this area, particularly for the school age children, which I think about between 6 and 11 years of age. In terms of just some of the limitations of the current randomized controlled trials in kids, as I mentioned earlier, they've been primarily done in adolescents. Very few include child report of sleep and daytime functioning. And I think, in terms of developmentally, 6 to 11-year-olds can complete reports of sleep and daytime function. I think it's a really important point or a measure to capture when you're working with kids, to not only focus on the parent, but also the child and include them and get measures of child report of how their perceptions of sleep, daytime function, and so forth. The sample sizes have been small, so most of them are anywhere between 30 subjects and 60 subjects. And, with these RCTs, there was a high risk of bias because lack of blinding, because you're actually giving CBT, it's hard to blind. But attention control groups could help that, and very few of the studies had attention control groups. And then there have been a lot of heterogeneity in terms of the participants. First of all, age 7 to 20, it's broad. And then as well as the treatment regimens and delivery. And then thinking about, longer follow-up periods, but really, if we're thinking about sustainability, really thinking longer follow-up periods, which it's easier said than done. But it's an important piece if we really want to capture sustainability and the effect of an intervention over time. And then, thinking about the gaps in just pediatric sleep, we have a lack of providers that are trained in pediatric sleep, specifically in how to manage behavioral sleep problems. It's not in our current nursing or medical school curricula. And if there is, it's very little. And it likely focuses more on sleep apnea. So, managing behavioral sleep problems isn't easy. It's a behavioral change and it's iterative and takes time. Some of the challenges we're up against too is long waiting times and referrals in pediatric sleep centers, anywhere from 4 to 6 months. And then the cost and time, right? Missed work and school for children and parents. Thinking about interventions, many of the interventions haven't involved our important stakeholders, which are children and their caregivers. So they're not involved in developing the intervention. And so this is where community-based participatory research comes into play. How do we really center our kids and families, communities, whoever your stakeholders are, in the development of an intervention? Because at the end of the day, they have to use it, right? And so really rethinking how we're approaching intervention development. And then with children, how we incorporate both parents and kids in terms of working together to problem solve, to go set up goals, and tapping into important measures of self-efficacy, engagement, motivations, which could be really important mediators in terms of the intervention and its effect on important health outcomes. And then few interventions are really focusing on marginalized communities. We know interventions work for some higher income, but how can we really kind of step back and think about the greater good and all of our communities? So in terms of mHealth, eHealth, what I mean by that is the use of mobile technology to improve sleep. So either mobile applications or web-based applications or text messaging. And in kids, unlike adults, in children, few studies have really examined mHealth to improve sleep in children. There has been work done in the infant population and mHealth. So for example, Jody Mandel and her team, Ariel Williamson, and Eric Lichtman just published a paper in behavioral therapy, looking at younger infants and toddlers, but less so in really the school-age children and adolescents. And then how do we think about, if we're really focusing on school-age children, this sense of shared management and what that is? So how we really empower both kids and parents to work together to set goals and problem solve. In other pediatric populations that have used mHealth to focus, let's say, on pain, shared management, so activation, engagement, have been important measures in improving outcomes. So some of Tanya Palermo's work in adolescents with chronic pain, and Cecilia Valerie and her work in sickle cell disease. They've done some really nice intervention work and highlight the importance of these self-management measures in terms of how to keep kids motivated and self-efficacy. And then few studies really have actually looked at both the parent and child dynamics. So some of Tanya's work have, but the majority of other studies have not. So how do we really think about that in terms of developing and moving forward in terms of changing sleep? So these next few slides, I'd just like to share a little bit about community-based participatory approaches. And what I think about is user-centered design approach, because we were interested in using technology because that's what kids are familiar with it, parents are familiar with it, but how do we integrate them in terms of developing an intervention? So getting a sense of what they want, what our stakeholders want, what are their goals, what are their needs, and then that can generate a lot of ideas in terms of us getting a sense of their likes, dislikes, and so forth. And so this circle here, it's an iterative approach. And the next few slides, I'm going to drill down a little bit in terms of how we have done that in our work. First and foremost, thinking about your stakeholders. Who are they? In our case, it's caregivers and children. And for some of you, it might be healthcare providers as well, or childcare teachers. So really getting a sense of your stakeholders. And in pediatrics, that is important, particularly for younger kids. So thinking about our community, and for some of you, working with, I think about Monica Ordway, Lois Sadler, and Nancy, some of their work in the childcare centers. So some of your key stakeholders are going to be those teachers, and how you kind of integrate them as well in terms of developing an intervention. It certainly makes it more complex, and it takes a longer time to develop, but it's also for the greater good in terms of thinking about sleep in children. So what we do, we have brought in families, usually anywhere from 5 to 10 dyads, where they come into our school and we do a participatory design session. So we will actually have parents and their child work together and look at 3 different websites. And then they use Post-its in terms of kids have their Post-its, parents have their Post-its, and tell us about what they liked and disliked about each of the different designs and other ideas that they have. And so then we have each parent-child dyad just present a little bit about what they liked, disliked, and ideas. And we videotape this too. So it gives us a sense of what their needs are. And I should take a step back here too. When I say the we, it's myself, research assistants, many of whom are computer scientists, humans, engineers interested in design development, human-centered design approaches. So it's a really, and an informatics folks as well. So it's very dynamic in terms of when we're really working with families. And then, and they're with us for a few hours when we do these participatory designs. And then we break out the kids into groups of 2, and then the parents in groups of 2, and actually have them sketch out. Okay, so kind of sketch out, dream big. What would a web-based intervention look like, or an application? And so kids are great at this. They will just working on the floor, kind of sketching out what they want. And you can see here that they want a section for health. And within that, diet and school and doctors and clinics and are in that subcategory. And then they wanted another section for really important community events like a Jingle Bell Run or the JIA camp. And then they want a separate section with sports, and they want a video of a child talking about living with arthritis and how they can still play basketball. And then here in terms of pain, and they want under pain, like medications, how to manage it, what to do if they break something. And again, another video of a child sharing her lived experience with arthritis and pain, and a little quiz here. The parents, they struggled with this. They kind of needed more probing about what exactly we were trying to get at. And so you don't want to say too much and bias them, but parents came up with 3 different sections here, like a kid zone, a teenager zone, and an adult zone. And within that, it broke out into different sections. They wanted a sense of, having a smartwatch that could look at their sleep and link it to their symptoms, so it was convenient and real time. And they were also worried about privacy issues, like, all right, so who sees my data and where is this stored, et cetera. And I'll talk a little bit about that in a bit. So this, again, gives you a sense of how this participatory design approach is developed. And then from there, we develop a web-based application based on their wants and needs and likes. And so here we're actually in the home and videotaping this. And we actually work with them for about 2 hours or so, where they think out loud as they're going through the website and tell us what they like, whether it's colors or too much content, or this is missing, or this is confusing, and so forth. And it's really to get a sense of importance in terms of features. If there's burden, how satisfied are they with this particular website, and which one do they like better, and so forth. So the goal here is to really meet their the end users' needs and wants. Okay. And if we're missing certain features or not. And this whole process takes easily 1 year for us, easily, maybe even a little bit longer. We were fortunate at the University of Washington. We have a good collaboration with the engineering school as well as the computer science school. So we really collaborate with them quite well. And this couldn't be done without the students. I mean, hands down. I learned so much from working with the students, who are way more up to date with technology than myself. And so this is what the students, the family wanted, the Sleep Smart. They wanted space. They wanted nice colors, soft colors, because it reminds them of sleep. And these are the key components we included, key cognitive behavioral therapy and components we included. And, I was fortunate to work with Tanya Palermo, who has done CBTI in chronic pain and successfully launched a web-based application. And this has taken Tanya probably 10, 12 years, but she was a co-investigator on our study. So I really want to recognize and acknowledge her and her expertise, as well as Allison Harvey, who is a psychologist at Berkeley. And Allison really does beautiful work on a transdiagnostic approach to sleep. And so she has shared her protocols with us, her slides, etc. So we really leveraged some of what she did in the adolescence, but we revised it for school-age children, 8 to 12 years, and pilot tested this with them. So I really want to call them out and thank them for sharing and really thinking through this with our team. Here is just an example of some of the modules we use. So it's 8 weeks, and embedded in each of our behavioral, the Sleep Smart module, we have goal settings, behavioral change, education. So, and we have a sleep coach that is a psychologist who checks in with the families each week for a total of 6 to 8 weeks. So every family starts out with the education model, and then from there we personalize it. So kids who are really struggling with a routine, they're going to continue with module 1, establishing a regular routine, a wind down window. And other kids who might be struggling with anxiety or rumination at bedtime, they're going to get, after the sleep education model, they're going to go right to module 3. Okay, and then over time, everyone gets these different modules, but we really try and personalize it based on the child and parent struggles with sleep. Oops. And then this is a weekly email that we send to families. So trying to keep it really simple and concise. And again, this was all part of the usability testing. So parents really dictated what this should look like, and it was helpful. This was easier said than done. But they would get an email each week, and these links send them to the Sleep Smart site. There's one for child, there's one for parents, and then within that site, we have, here's an example, the sleep education site. So within that site, there's a short video, 10, 15 minutes, an interactive quiz, about 5 questions, because we wanted to make sure that when they log on, they actually are doing the content, learning something. So the quiz was a way we could kind of capture that. And then they had activities each week, and working with the sleep coach. And then we had additional resources underneath there, some for kids and some for parents. And this is an example of, this is REDCap we use. So once parents would click on the link, or kids to different assignments or talking about their goals, it would just send them right to REDCap, and they could free text in here and then upload any assignments. I think this is one area where we could change. This was fine, but just making it a little bit more convenient. And I can talk about that in a bit. So we are finishing up that trial, and we hope to have we're working on the findings and hope to have them out or under submission this summer. So stay tuned for that. We did write a bit about the intervention development and nursing outlook 2020 paper in January to tell you. So if you want additional info. Now I'm going to switch gears and talk about some mHealth interventions that actually have been implemented. One is called Better Nights, Better Days. And this is Penny Corkum in Canada and her colleagues. And this was specifically for ADHD. They were interested in looking at the effect of a distance, Better Nights, Better Days intervention on children's sleep latency, bedtime resistance, and sleep duration by parent report. That was their primary outcome. Their secondary was to look at actigraphy changes in sleep duration and sleep onset latency, and then behavior changes. And so they were curious. There were kids with ADHD, and they also looked at typically developing kids. So again, Penny and her team used cognitive behavioral therapy components here. There were 5 of them, and they had a sleep coach. where they had weekly telephone calls, anywhere from 30 to 45 minutes with the sleep coach. And parents had a manual as well. And so the children in this study were 5 to 12 years of age, and they were really interested in kids who are struggling with falling asleep with or without bedtime resistance. And they operationalized that as sleep onset latency greater than 25 minutes and occurs more than 3 times a week. And the duration of this had to be at least a month. And kids with sleep apnea were not included, as well as kids who had comorbid anxiety, depression, and ADHD. So they were truly just looking at kids with ADHD. And if any children participated in a behavioral sleep intervention over the last 6 months were excluded. So they had 61 kids. Of those, 31 had ADHD. They used actigraphy and parent report. It was a small trial, 5-week intervention, and then they looked at the 2-month window and then 6 months post-intervention at some of the effects on sleep. And so most of the kids, they were about 9 years of age, primarily female, I guess it's 50-50 female, male, primarily white. And most of them were on medication for ADHD, of course. And they had half of the kids in each group, some had ADHD and some were typically developing. And so, they had improvements in parent ratings of the Children's Sleep Habits Questionnaire. So they found some improvement in sleep onset latency, bedtime resistance, and duration by parent report at the 2-month window and then 6 months post-interventions. The effects were small to moderate, 0.2 to 0.4. Similar to the adult studies, they didn't find actigraphy differences over time at all in 2 months post-intervention and 6 months. And a bit about why. They had low adherence to actigraphy. So of the 30 children, 14 of them in each of the groups, only half wore the actigraphy for the week. So that may or may not contribute to some of their findings. I think they didn't have a child report of sleep habits or daytime functioning. And I also think that by the end, that 6-month post-intervention, the children's sleep habits total score was still above the cutoff for sleep disturbances. So even though they had some movement, not as much. So in other words, the kids still had sleep problems, and maybe 6 months isn't a long enough time to see change, or perhaps the measure. I'm not sure that the Children's Sleep Habits Questionnaire measure maybe it wasn't sensitive enough to detect the change they wanted. Perhaps maybe the Children's Sleep Habits, Sleep Hygiene Scale might be a better measure. And then there weren't any measures of self-efficacy or motivation, but nonetheless, it was a start for them to think about mHealth intervention. And they have since revised it. Now it's still called Better Nights, Better Days, but they're really scaling this. And her work's definitely something for us to keep an eye on. She scaled it to ADHD, and then now they are looking at kids with neurodevelopmental disorders and then typically developing kids. So it's the same ingredients in terms of the intervention, but little tweaks in between for the different types of kids with chronic conditions. So I think she's really done some nice work. And so I want to just share a little bit about this. They're interested in this intervention on kids' sleep and psychological functioning. It's parent led, and they really wanted to use technology because it's accessible, it's easy, it's convenient, and it mitigates folks from having to come to a sleep center. or miss work in school. And the goal is really to empower parents to implement these strategies independently. It was based on evidence-based practices, and they have it personalized. So in terms, they're looking at kids 1 to 10 years of age. And so they're focusing on 1 and 3-year-olds versus early school age, 5 to 8, and then middle school age, and then adolescents. And I think that's really smart because the type of videos you do, the type of interaction elements really will vary by age. And so they are looking at 1,000 kids. They published their trial in 2018. They don't have the results yet. They're working on that now. From what I've known, they have seen an effect. And what's nice about this is a randomized control trial across Canada. So they have nurses, psychologists, physicians, et cetera, all on these sleep researchers on this, involved in this study. And it was funded by the Canadian Institutes of Health Research. So kids are either randomized to usual care or this intervention, which is 5 weeks, and then they're doing a 4-month and 8-month follow-up. And she's really interested in scalability, so implementation and sustainability, getting a sense of who this intervention works for and who it doesn't, but with an eye towards to really scale it. And if you want to learn more or hear more about this group, this website is helpful. So that'll be an important study for us to keep in mind. This is just a bit, it's bilingual, English, French. They're focusing on the sleep onset disturbance. So stay tuned. There's no results yet. I just emailed her the other week, and I'm really anxious and looking forward to what they find. And this last study is published, and I'd like to share it it's from the UW Center for Innovation in Sleep Self-Management. And it's called a web-based sleep intervention for kids, or SKIP. And Dr. Sani was the principal investigator. And so this was really tailored for 6 to 11-year-old kids with moderate to persistent asthma and their parents. And it was really geared on feasibility and acceptability, and really exploring can we make a change in sleep over a short amount of time. So children were 6 to 11. Here's some of the inclusion criteria. We define sleep deficiency as inadequate amount of sleep and or poor quality sleep, and a cutoff score of greater than 41 on the Children's Sleep Habits Questionnaire. And Jen was also interested in parents who were sleep deficient, and so she used the Pittsburgh Sleep Quality Index as a marker of that. And so this was a 2-year grant, and the first year was really to develop and doing participatory design, usability testing with parents and kids. And so she had a baseline sleep assessment. The intervention was over 8 weeks, and then immediately measured sleep and other outcomes, and then 12 weeks later. She did not have a control group, so it was really single single group. Parents and kids both wore actigraphy and completed reports of sleep and symptoms, because she's very interested in the dyadic approach. She obtained additional measures on spirometry and height and weight. And then in terms of getting a sense of how engaged and goal setting, et cetera, she developed surveys for that and semi-structured interviews. So 3 modules were chosen: bedtime routine, sleep environment, or sleep quality. And the reason or how they were chosen was really based on her pilot work with these parents. These were the key components they thought were problematic. And so within each of these modules, there is a short video, 8 to 10 minutes long, and then weekly activities, goal settings, kind of getting a sense of barriers and problem solving. And then they would get weekly progress reports. And it's iterative. So in terms of getting a sense of their goals, Jen would work with them and the research assistant and working through them each week. And once they got through their goals, then they would get go to the next module or stop. All right, let's kind of rethink and problem solve. And then kids would give her feedback, and parents, like, is it going well, thumbs up, or not, thumbs down, and working through it was kind of a neutral thumb. So in terms of the results, parents liked it in kids. She had a total of 25 dyads, and of those, 61% of children and 92% of parents were satisfied. They agree or strongly agreed with the progress they made and just the acceptability of the design. Most of the let's see, 25 dyads, 12 completed all of the modules. Most of the caretakers were mothers or self-identified as moms. And let's see, she did see some improvement in terms of sleep. So bedtime consistency, WASO, and sleep efficiency here. She did see a change 3 months. And the same thing with parents and sleep efficiency and consistency for parents. Less so for sleep duration. And that seems to be true for adults as well. And it actually is consistent with other studies, and perhaps just looking at duration isn't sensitive enough. But nonetheless, she's working on, it was feasible, acceptable, and effective. She is working on refinements. We actually just met yesterday. So thinking about some of the components we're doing in Sleep Smart, could that be used for asthma? So we have to pilot test that and make some refinements before testing in a larger trial. And it takes time. It takes a lot of time to really work on these mHealth interventions, but it's worth it. I don't think I mentioned earlier, talking about the Better Nights, Better Days with Dr. Corporal. She spent a total of 7 years to get to where she is now in terms of launching this randomized controlled trial across Canada. So it definitely takes time and a lot of money. But nonetheless, it's doable. So, thinking forward, I think it's really important how we really center our families and having them and using community-based approaches to develop interventions. That's really critical for engagement, adherence, and sustainability. And then thinking about who we're including or not including, right? And what these interventions, who they're working for or not. So mHealth will work for some kids, not all, but getting a better sense of who that is, we don't know yet. We're still early phases here. I think it's important to share protocols, and it's a big ask, but it's important. And so we, are consistent in how we do things, and sharing our lessons learned. So, for any of you who are interested in our protocols or our lessons learned, and so forth, we would be happy to share those with you. And, I think the other two key pieces here are technology to measure sleep. We used actigraphy. Actigraphy is expensive. And kids can't keep it, or parents. So, technology is not going anywhere, and it is, as Sam said, accelerating. So eventually there's going to be some watch that is, and probably already does, really capture sleep accurately. And how do we get in front of that and integrate that in terms of our intervention. And then thinking about the platform you use for your design and how it communicates to the hardware, that's complicated. And then security and privacy issues are a big deal to families in terms of who sees the data, where's it going, and where's it being stored. Those are all important things to consider when you're thinking about mHealth in pediatric populations. So before I close out here, just want to share some work at the UW. Dr. Ira Kantrowitz-Gordon, he just published a intervention looking at pregnant mothers with depression and a mindfulness sleep management intervention. Wei Chao Yuan is looking at preschoolers with arthritis, and also working dovetail with Maggie Ramirez, looking at Latino caregivers of children with special healthcare needs, and they're integrating a chatbot. So probably over the next year, you'll be reading a little bit more about their work. Tanya and I, she has a web map intervention for adolescents with chronic pain. And so we actually put in a module for sleep, because there's that was an important component that wasn't in her initial web map. And so that should be coming out soon. Karen Redding's doing some work with breast cancer survivors and chatbot. So we have a chunk of folks who are really interested in the chatbot phenomena. And so that's fairly new, and we'll see how these develop. And then lastly, I can't thank the children and families enough, all the grad students that worked with us. They were a delight. Our program and outreach coordinators, Allison Harvey, Tanya Palermo, and then we were able to secure a small endowment from the Barbara Snyder Foundation family. So we're very grateful to them. And of course, National Institute of Nursing Research for funding this. And then lastly, this is our team. It's psychologists, informatics, rheumatologists, pulmonologists, engineering, public health, epidemiologists, and so forth. It takes a village, and they've been an absolute delight to work with. So thanks for your time, and I'm happy to answer any questions you may have.
Thank you, Teresa, for your excellent talk. We realize that we've asked people to use the Q&A box, but we realize that for some reason the panelists cannot do that. And I'm expecting that some of the panelists may also have questions. So I will manage both the chat and the Q&A box. So please post your questions as soon as possible. Teresa, I have a few questions. As you know, I'm completing a clinical trial looking at CBTI in people with heart failure. And there's a huge, what we're doing is pretty much a standard CBTI, although it's been applied to multiple adults with chronic conditions. And I'm wondering, how similar are these approaches across? You've looked at ADHD and arthritis and asthma, et cetera. And how much do the interventions need to vary? And how tailored are they to these specific conditions?
Yeah, it's a good question, Nancy. I think I think in terms of kids with ADHD and typically developing kids, I think they're similar. Once you get into kids with autism and some of the neurodevelopmental disorders, so I haven't done work in neurodevelopmental or autism I have, but we haven't developed an intervention. But just clinically working with those families, can take much more time. I think the components for CBTI, they're similar, but the approach and the personalization is what changes. You know what I mean, Nancy? So getting a of, what are families' resources? That varies, and child temperament. So I think the end goal is the same, but that how you approach it is different.
Thank you. So the other challenge we have, and you mentioned this in the beginning, with many behavioral approaches, is that there's a shortage of. It used to be mostly sleep-boarded psychologists, and increasingly nurses are doing these and others are doing these interventions. And so when we think about long-term uptake into the real world and implementation, how will we implement these once we do all this testing? How will we get them out into the real world? And what is the reimbursement like? And again, we don't know all these interventions, but thinking about implementation and effectiveness, how will we pay for this and who will do it?
Yeah, that's a great question. Because reimbursement's always an issue. I mean, whether you have mHealth or not. I think, sustainability. So yeah, it's the funding, like who kind of maintains the upkeep, if you will, of the hardware, the software, the platform. And I don't have an answer to that. I mean, that's time will tell. And I'm not sure, with reimbursement, and how that's dictated by insurances. Again, maybe, I don't know. I mean, maybe you don't get reimbursed in terms of I'm thinking out loud. If you have mHealth intervention and you want to scale it and help families, maybe intervention isn't part of that. I mean, reimbursement isn't the metric you're looking at. You're looking at to improve outcomes. And I realize that's a push-pull if you're in clinical practice. But, at the end of the day, if the goal is to improve sleep and help as many families as possible, in scaling it, do they pay just to get, let's say, the app and that's it? Maybe it's thinking about it like that. I'm not sure if that answered your question.
No. I think we all struggle with that as we do these efficacy studies of the long-term uptake across, in multiple modalities. So the other question I have, I was very interested in your think aloud approach with the Post-its, and most of us have now, for the last year or so, had to move to doing everything virtually. And I was wondering what your thoughts are about if that approach could be used in a virtual way, or do we need to be face-to-face to use it effectively?
Yeah, that's a good question, Nancy. I think it could be done virtually if you had a whiteboard. I think the challenge is, the stakeholders. Is everyone familiar with Zoom and how to use a whiteboard? And, there's a lot of variability there. So if they had some instructions in how to do it, yeah, I think it's possible. I think it's a little bit more, Zoom's tough. It's really, right. It's convenient, but just to get that engagement, it does add a whole other layer, as Sam mentioned. So yeah, if you had to do it, it's possible. Using whiteboard, but it's that engagement piece where and you do have breakout rooms in Zoom, so you could break them out and have them work in different groups and each have their own whiteboard. So yeah, I guess it'd be possible. Yeah.
Okay, thank you. Oh, there are questions. I didn't see any questions here, so I was doing too much talking and they weren't coming up. Okay, let's see. Okay, let me see what's here. So I'm working off two boxes. I apologize.
I see one, Nancy, from Monica.
Yeah, can you see it?
Yeah.
Why don't you answer it since you can see it, because I'm working off two boxes here.
Yeah, no problem. So one was, can you ask if they had ideas to what was the limiting factor to children wearing the actigraphs? Yeah. So I think this was from a study with the ADHD kids, and she didn't mention that in the discussion. She mentioned kids didn't wear it,
but as to why, I don't know. So I don't have that data. We haven't had that problem. I mean, we have kids, we tend to have, I've used actigraphy now in preschool kids around their ankles. We use fun things like a sock. They can pick out their favorite socks if they want to wear it around their ankle, or look, mommy has a watch, so do you. And so that works really well for preschool kids. And school age kids don't mind it either. If anything, sometimes it's irritation, but for the most part, our kids have worn it. Maybe not for the full, 10 weeks, but we can get a good chunk of 7 days of data, 7 to 9 days of data. What I do recommend when you're using actigraphy, ask them to wear it for at least 10 days, 10 to 14 days. So at least you get 7 days of data, weekday. So hopefully that helps.
So Monica also said sleep hygiene is a vital component of childhood health, tethered to children's physical and mental health. However, sleep hygiene health disparities exist among toddlers from racially, ethnically diverse families who live with adversity as early as 12 months of age, and that's from Monica's work. There's a gap in the current literature that includes environmental factors and may explain factors contributing to these differences. And we wondered if you had any comments on that and how we might incorporate some of that into interventions.
Yeah, so thinking about, let me make sure I got it right. Marginalized communities and their sleep and beliefs or resources.
Yeah, so we talk, we always give sleep hygiene. We do this for adults too, and we talk about sleep hygiene, and sometimes our, what's the standard is often tailored to people with resources. Yeah. And so I think part of the question is, how do we tailor this, and how do we work with sleep hygiene and stimulus control and environmental inputs in families where everybody, for example, doesn't have their own bedroom, or it might be noisy, and so what are your thoughts about that?
Yeah. So I think it's critical to get a sense of what are their resources, like getting a sense of what they want to change. The resources may not be the same. They only have one bedroom, let's say. That's fine. So how do we work around that and really working with them to see what's feasible? So I'll give you an example. Like one of our families, one of the parents worked till a few different shifts, and so didn't get home until 8:30 at night. And the dad said, I want to talk to my child, right? So an 8:30 bedtime isn't feasible for me. It's really 10 o'clock because I want to spend some time with. It was really important to them, and that's totally fine. So you work with that. Okay, so let's think about what that routine would look like, and is there more sleep opportunity, let's say during other parts of the day, like a nap. This was a young child. So getting a sense, working with families and what they're up against, because it's not going to be the same for folks who are in marginalized communities. I also think it's really important. This is where kind of a mixed methods, the qualitative research comes in. Really, you can get some beautiful data. Getting to understand what sleep problems are to them. What does that mean to them, right? Not assuming, and that's easier said than done, but probing and getting a sense of, what is for bad sleep? What does that look like to you? And that can help you guide and retweak some of these interventions and working with them within the constraints that they're at.
Great. Okay. So Lois Sadler says this is more of a comment than a question. The work presented today is a powerful tribute to the importance of community engaged work with children and parents in designing, refining, and implementing meaningful and feasible sleep interventions. Congratulations.
Oh, thanks, Lois.
And then we have a comment from James, a question. While we await mHealth intervention implementation, what can primary care providers do to improve sleep health, especially in areas where sleep specialists are not readily available?
Yeah, that's a great question, Jane. So I think if it's connecting with some of the centers that have
pediatric specialists. So for example, if you're wherever you're at, connecting with Monica and Craig, who are part of the sleep center, pediatric sleep center, and is there a way, whether it's monthly or quarterly forum, getting a sense of what you're up against as a PCP and connecting with some of these pediatric sleep docs to see, or excuse me, practitioners to see if there's a way they can leverage some resources, or for some of the families that come to the PCP, is there like telehealth? Could these folks, see Monica and Craig, for example, in their sleep center? It's $1 million question, to be honest, because just having videos about cognitive behavioral therapy or how to isn't enough. You really so nuanced with behavioral change, and or shadowing, if that's possible, or maybe having a students who are trained in cognitive behavioral therapy, could they do, and sleep, could they come to some of these clinics that don't have sleep specialists, and could they help kind of facilitate some of this training?
Great, thank you. Let's see. Allison Moriarty Daly, who studies adolescent sleep, says telehealth.
Yep.
So, okay, so that picks up on Sam's talk. Anyway, okay, I don't see any more questions in the box. You all have a minute or two if you have additional questions. This has been great, Teresa. I'm going to take the liberty. Oh, okay. Oh, and Allison does school-based health. She's a nurse practitioner in school-based health clinic.
We need school. We should chat.
Yeah, you should connect with Allison. We will. Yeah.
Sleep health in school-based. That is an untapped area.
Great.
Yeah.
Good. Thank you. So I'm going to take the liberty of giving everybody 5 minutes for a quick drink or whatever break, and to come back and make sure you're back at your computer at 12:20, and Klar will continue with sleep research, and we'll do the posters. Thank you so much. Great talk, Teresa.
Thank you.
And get started. Going to take a few moments to highlight some of the research developments at the Yale Center for Sleep Disturbance and Acute and Chronic Conditions. And then we're going to transition right from that into some of the poster presentations, which I think will also will be engaging. What this particular conference emerged out of a center grant that was a collaboration between the Yale School of Nursing and the Yale School of Medicine. And I think inherently sleep medicine is a multidisciplinary field, and I think ripe for team science approaches to asking and answering questions. And I've always felt that sleep medicine is this watershed field in between different specialties, which I think is where some of the very interesting questions get asked and answered. But the initial grant, center grant that was funded, had several specific aims. The first was to expand the number and the quality of research studies done at our institution, examining some of the biobehavioral relationships between sleep disturbance and acute and chronic conditions, looking at the contributions of sleep disturbance, sleep deficiency to morbidity, mortality, function, quality of life, and really think about how sleep deficiency, sleep disturbance impacts these conditions across the trajectory of acute and chronic conditions. There were also some infrastructural goals to build and sustain partnerships both within our institution, but also external partners, and to expand the research infrastructure at Yale to permitting interdisciplinary research and collaborations. And the conceptual framework that we have used, many of us have used in our research activity, sort of embraces this model and goes like this. And so in the context of an individual patient participant's predisposing biology, sleep disorders, other medical and psychiatric mental health comorbidity, etc. What influence does sleep disturbance, does sleep deficiency have across the trajectory of acute and chronic conditions on important outcomes, on function, on cognition, on symptoms, on morbidity, on quality of life, healthcare utilization, and mortality? And importantly, what impact do sleep interventions have on these health outcomes? And a number of the studies that you've heard about today and that you will be hearing about sort of have incorporated this conceptual framework, this conceptual model. And since the Center Grant, which was funded over 6 years ago, I think there's just been, even in the last year, from our respective programs, a huge number of funded grants that have been successfully funded and are up and running and underway. There's studies looking at the relationship between sleep deficiency and opioid use disorder that share a number of sleep deficiency and opioid use disorder share a number of common cognitive impairments. Looking at stroke, looking at R01s, looking at heart failure that Nancy runs. Collaborations looking at the impact of circadian rhythmicity on immune response and among older adults. Dr. Koo recently received funding through the DoD related to melanocortin hormone and restless leg syndrome, and looking at REM behavior disorder as a biomarker, an early predictor of Parkinson's disease at a time where immune interventions may actually have some important therapeutic impact. But in addition to these larger research grants, there have been a number of other R-level grants, R21s, R34s, Patterson grants. The American Academy of Sleep Medicine has funded investigators at our program. Dr. Griggs in sleep and self-management and glycemia control in young adults with type 1 diabetes. Interventions using Dr. Facito using wearable technology to influence heavy drinking in young adults. Dr. Connolly looking at rest activity patterns and in inflammatory bowel disease, promoting interventions in early Head Start program. Dr. Knauert, who was one of the early recipients of one of the pilot projects from the early Center Grant, now getting funded with R-level grants and putting in R01 grants, looking at the feasibility and examining circadian rhythmicity in the ICU, or measuring sleep deficiency now in older adults. Dr. Miner, who is a geriatrician and sleep medicine specialist, as well as even looking at sleep deficiency among incarcerated individuals, which provides some very interesting insights. And finally, I think most excitedly, we have a number of folks now who are putting in and getting funded career development awards. Dr. Knauert's work in, again, looking at circadian desynchrony as an important therapeutic target in the ICU to potentially help improve outcomes in terms of delirium and metabolic function. And Dr. Zinchuk recently got his K23 awarded looking at some of the physiologic traits that can predict adherence to CPAP use. Dr. Griggs, again, looking at type 2 diabetes, again, looking at sleep deficiency among older adults, and a number of F31s taking unsupervised analytic approaches using symptom cluster profiles, with Dr. Brazil, and toxic stress, and with Dr. Condon and cognitive function in older adults who survive critical illness. And so it's been amazing just in the past year, the amount of funding that is coming to the institution, and the work that is being done here. And so I think to sort of continue on in this fashion, we're gonna shift over now to looking at some of the posters that will be presented. I think there's 20 posters and presenters who will be presenting their work today. And I thought I would throw up this sort of joke slide entitled "The Yawn and Order Sleep Medicine Unit." In the healthcare system, apnea and hypopnea-based offenses are considered especially heinous. Our dedicated team of sleep specialists, technologists, and researchers are part of an elite squad known as the Sleep Medicine Unit, and these are their stories. And so this was a sort of a prelude to looking at some of the poster presentations. Unfortunately, on Zoom, you can't hear any laughter, but I assume there's a lot of laughter going on right now. All right, so let's get started. The way this is going to work is all of these posters are available to the participants in this symposium on the website, which is indicated on the agenda that you received for this symposium. And what we're going to do is ask the presenter from each of the poster submissions to take 2 or 3 minutes to present the main findings of their work, and then perhaps have a minute or so for questions. We're going to, because we have 20 posters, going to stick to a strict timeline. And my recommendation is for us to use the chat function as well. And so when participants have any questions, please put that in the chat, and we'll ask the presenters to monitor the chat and respond to those questions after they've completed their presentation. If there's time at the end of the presentation to go through 1 or 2 of those questions, we will do so. But and so when you put in a question into the chat, please put it in and send to panelists and attendees, and again, have our presenters try to respond to those questions if we aren't able to get to them in the discussion. And so I think we'll go ahead and start with Dr. Olu Adekolu, who is going to present his group's work on the influence of chronotype on CPAP adherence. Dr. Adekolu, are you here?
Yes, I'm with you.
Wonderful. All right. Take it away. You have a couple minutes.
All right. So basically, the work we did was to look at the influence of chronotype on CPAP adherence. Just a brief background. CPAP, we know, is an efficacious treatment for obstructive sleep apnea, and we know that despite the interventions that have been done, adherence to CPAP remains poor. We identified chronotype as a possible factor that could influence adherence based on previous work, and that has seen chronotype influencing dietary changes and alcohol use. And then we hypothesized that chronotype will be associated with CPAP adherence, and our aim was to identify the mechanisms. So we did a secondary analysis of data from the HAPUS study, which is a study that was previously published to look at the effect of CPAP therapy on neurocognitive outcomes. Our exposure group was chronotype categories determined by the MEQ score, for which we identified the morning, the evening, and the intermediate categories. Our outcome was daily average CPAP adherence over 6 months, measured in hours per night. And we did more like a linear mixed modeling effect to examine the associations and examine mechanisms based on beta coefficients. Which regards to our results, baseline characteristics, morning chronotypes were 44%, NIDA 47%, and evening chronotype 8% in terms of our cohorts. The evening types were youngest, they had the highest BMI, they had more social jet lag, they had more symptoms of insomnia and fatigue. And then with respect to the primary outcome, as we can see from figure 3, which is a figure showing adherence in hours per night on the y-axis against CPAP time from initiation on the x-axis. And then the green light is the green line is morning chronotype, red is NIDA or intermediate, and blue, red is evening and blue is NIDA or intermediate. As we can see, there was really no difference between the evening and the intermediate chronotype. However, for the morning type, there was a significant higher CPAP adherence on average of about 41 minutes per night, which decreased slightly after we adjusted for our predetermined, covariates and confounders. And this association remained relevant even when we checked CPAP adherence based on the Centers for Medicaid and Medicare Services criteria. Overall, in conclusion, we think this is a novel finding. No one has really looked at this before. We weren't able to identify potential mediators for this relationship because even after we tested for all of our mediators, none of them seemed to play a role here. And, chronotype may be a modifiable factor amongst the biopsychosocial PAP adherence determinants. Thank you.
Excellent, Dr. Adekolu. A question that was put in the chat is, why do you think chronotype might influence adherence? What mechanisms?
Yes, so it's been previously shown that chronotype influences behavior. It's been shown with alcohol use, it's been shown with substance use, it's been shown with dietary adherence. And one of the mechanisms is, in general, people who are of a morning chronotype, they tend to be better motivated. They tend to have better attitude as opposed to people who are of the evening chronotype. Again, people who are of the evening chronotype, because of the social jet lag that keeps developing over time, they tend to be less, less adhere, with behavioral changes. So that was part of what we thought about initially with the study.
Thank you, Dr. Adekolu. All right, we're going to move on to our next poster entitled, I'm just going to decrease the size so the whole poster fits on, entitled Sleep Disorders After COVID-19 Infection at Yale New Haven Sleep Center. And Dr. Glinda Bowen will be presenting this work. Dr. Bowen?
Thank you, Dr. Yaggi. So I'll get right to it. The prevalence of sleep disorders has risen during the COVID-19 pandemic. Patients who were previously infected with the virus appear to be the most affected group. The primary objective of this study is to catalog the clinical features of these patients in our community. We conducted a retrospective review of the medical record of 100 patients seen in our clinic from March 2020 to February 2021 who had previously tested positive for COVID-19. These included new consults and established patients. Table 1 shows demographic characteristics. 58% of patients are women, 47% were African American, 15% Hispanic, 35% white. 77% of patients had a BMI of 30 or above. In terms of severity of disease, 1/3 of patients were hospitalized, with 10% requiring ICU admission. As you can see in figure 1, the most prevalent sleep disorders in this cohort were sleep disordered breathing, seen in 68% of patients, and insomnia, seen in 38% of patients. Snoring, fatigue, and excessive daytime sleepiness were the most common sleep-related complaints. It was interesting to see that a significant number, 21% of patients, presented with cognitive impairment. Hypertension, anxiety, and depression were prevalent comorbidities in patients who presented with obstructive sleep apnea and insomnia. We saw that more than half of the patients in this cohort were African American or Hispanic, which mimics what we have seen at a national level, with minorities being unequally affected by the pandemic. Hypertension and obesity, which are associated with severe COVID-19 disease, were prevalent in this cohort. We would recommend that all patients that have been infected with COVID-19 be screened for sleep disorders. Thank you.
Thank you, Dr. Bowen. That was very well put. What do you think are the next steps in this work?
Well, one thing that I did include patients that were established and new patients. And so I think down the line, looking at patients that newly present with new symptoms to kind of take away the confounding of the patients that already, had a diagnosis, to see really the true impact of the COVID-19 infection. I was hoping that with looking at different characteristics, developing screening tools could also be an option, and just educating. Interestingly, many patients presented with fatigue, which is a very non-specific symptom, but just kind of educating other providers to kind of prompt referral for evaluation for sleep disorders as well.
Very good. Very good. Thank you, Dr. Bowen. All right. Our next presenter is Dr. Steven Brazil, who will be discussing sleep disturbance, mood, daytime symptoms, and self-care among patients with heart failure and insomnia. Steven?
Hey, thank you. So this work we conducted using the baseline data from the heart sleep study, which is Dr. Redeker's 5-year R01 study. And the aims of this study were really two main-fold. Was one, to identify the common ways, or the way in which multiple symptoms that people who have heart failure and insomnia experience a set of symptoms. So we looked at 9 symptoms, including insomnia, severity, sleep quality, sleep disturbance, anxiety, stress, depression, dyspnea, fatigue, and then sleep impairment. So the daytime sleepiness is kind of the measure there. To see, is there an underlying factor structure of the way that these are organized? And then what are the effects of these underlying symptoms on self-care maintenance and self-care management, self-care confidence, which are key components of care for chronic illness, as most heart failure and insomnia care occurs in the home. And so what we found is that these symptoms grouped in 3 underlying latent factors, which we confirmed via exploratory and confirmatory factor analysis, where we had sleep characteristics, mood, and daytime symptoms. And then we also looked at certain, the effects of those latent variables on, and as well as certain demographic and clinical correlates on self-care maintenance and self-care confidence. And so what we found is that sleep characteristics, the latent variable there, which included insomnia severity, sleep quality, and sleep disturbance, were negatively associated with self-care maintenance. So therefore, people with worse sleep were less likely to have adequate ability to maintain their self-care, which is kind of the normal activities required to maintain heart failure. And then we also found that race, or being of white race specifically, and having an ejection fraction less than 45, were associated with better self-care maintenance. So there's some demographics and clinical correlates that we can start to identify individuals with. When it came to self-care confidence, age was the only significant significant clinical or demographic correlate showing that older age was associated with less self-care confidence. But that the symptoms, the latent factors themselves of sleep characteristics, mood, or the daytime symptoms did not appear to affect their self-care confidence.
Very good. Very interesting work. Nancy, did you have any comments on this?
Unmute. Thank you, Stephen. I think this is a very complicated situation. And, you know, one of the things we think about in sleep and sleep medicine all the time is what is the outcome on patients? And you know, in heart failure, and as you know, many of them also have sleep disordered breathing. In this sample, about half of the patients did have treated sleep disordered breathing as well as insomnia. These patients were recruited for that. And so this idea of how does sleep influence adherence, or how does sleep influence the things that people need to do to take care of themselves, I think is a critically important question. It's important, obviously, in heart failure, but also in many of the other populations whom we serve. Thank you, Stephen.
That's great work. And just as a reminder, I think this was put in the chat. As we said, all of the posters are on the website in the agenda, and the email addresses of the presenter are there. And so if there are follow-up questions after these presentations, feel free to reach out by email to the presenters and continue. Lorena Font just entered that website into the chat, but feel free to continue to put questions in the chat, and we'll have the presenters respond to them when they are able to. All right, so our next presentation is, let's see here, so we can get again, is Stephen. I think you're up again.
Yeah, so this is my dissertation work and the preliminary results. And so I'm an orthopedic trauma nurse practitioner, and this is my really area of expertise. So about 28 million Americans are injured and experience orthopedic trauma every year. And in addition to their orthopedic physical consequences, they're exposed to a whole host of negative psychological and emotional consequences. So pain, sleep disturbance, anxiety, depression, and stress-related disorders are really the most common. And continuing this sort of multivariate work, no one experiences just one of those symptoms, and no one experiences, or not everyone experiences all of those symptoms to the same degree. And so if we can sort individuals into these groups by the kind of bottom illustration here, which we call symptom cluster profiles, which is sort of how are the common ways that people experience the entire set of those symptoms, we could potentially identify phenotypes in people who are at risk for long-term negative outcomes. But these are also, the symptom cluster profiles are also thought to share a shared biological mechanism. And in my dissertation work, I'm looking at serum concentrations and genotypes of a protein called brain-derived neurotrophic factor, which is a neurotrophin that strengthens the connections between nerves. In the orthopedic population, in addition to the central nervous system sort of consequences of this protein, BDNF helps regulate angiogenesis and osteoblast function in across the fracture site. So we might be able to link psychological consequences of injury as well as physical recovery to really create a more comprehensive understanding of what's going on. This is busy with these slides or the tables, but the preliminary analysis is the first 74 participants of the study. We're hoping to have 150. And the main take home here is the symptom measures, where my sample does not appear to have clinically significant differences in their rates of depression compared to the general US population. Does have higher levels of acute stress disorder, where 17% of my sample had clinically significant symptoms of acute stress disorder. But anxiety, depression, and sleep disturbance are extremely prevalent, where anywhere between 40 and 50% of my participants report clinically significant levels of depression, anxiety, and sleep disturbance. So this preliminary analysis doesn't include the cluster analysis yet, and doesn't include the biomarker work, but just seeing the high prevalence of these symptoms in this population really highlights the importance of assessing these post-injury problems, and I think is promising for the full analysis, which we should complete this fall.
Excellent. Stephen, do you have data related to medication use, in particular opioid use?
But we don't in this study. That wasn't the main aim in the main aims. I can tell you that 100%, almost 100% of the participants are taking opiates in-house, just as a standard treatment for their injuries. But I think that's important to see sort of what are the pre-existing conditions. We did control for that in that the enrolled patients couldn't have these conditions prior to enrollment or be prescribed long-term opiates for chronic pain or be on psychotropic medication. So we've screened out people who had pre-existing conditions, but I think the next steps are to include those individuals to see how does pre-hospital exposure really predict long-term outcomes.
Interesting. All right.
Stephen, could you comment on where you're interested in taking this and talk about how this might inform future practice?
Sure. I think the important thing here is, expanding to include more biomarkers that are shared across the psychological outcomes as well as the physical healing. I think that's really speaks to nursing science of the holistic approach to healing these individuals. And I think that the way, 20-year vision is looking at self-management interventions as well as increasing standard of care in the acute trauma period that can work on these potential biomarkers and influence these recoveries. So, for example, ketamine is a great drug that's used in anesthesia. Roughly 80% of my participants underwent surgical fixation of their fracture. Ketamine has been shown to increase BDNF levels and be associated with lower depressive symptoms after orthopedic surgery. So should the anesthetic plans, even in these peritraumatic patients, be modified to help improve these long-term psychological outcomes?
Thank you very much, Stephen. All right. Our next presenter will be Dr. Yvonne Chu, talking about obstructive sleep apnea in pregnancy. Yvonne, are you there?
Yes. Hi, Dr. Yaggi. Thank you. So just a bit of background. OSA in pregnancy is common, and there are adverse maternal and fetal outcomes to untreated OSA in pregnancy. Because it is under-recognized and undertreated, we established a quality improvement program with the long-term goal of improving access and care for pregnant women at risk for OSA. Our methods began with a review of referral patterns and tracing patients through the entire process from referral to our Yale Sleep Center to treatment. Next, with our findings, we designed and distributed an anonymous survey to Yale-affiliated OBs to assess their screening practices and general perceptions about OSA. Our results show that the number of pregnant women referred to our sleep center for possible OSA is exceedingly low, with 30 referrals in a 5-year span. The time from referral to effective PAP therapy averages 21 weeks. Figure 1 summarizes the referral and retention rates between 2015 and 2020. There were 30 referrals placed for pregnant women, 25 had appointments scheduled, 16 kept their appointments. Of the 16, 12 completed their sleep studies, whereas 4 were no-shows or canceled. Of the 12 who had sleep studies, 8 were confirmed to have OSA, but only 6 had CPAP successfully set up, and 2 attended CPAP acclimation appointments with our respiratory therapist. In table 1, we see the average number of days needed for each step in the process. It takes an average of 64 days from referral to our first scheduled appointment. And this is by far the lengthiest part of the process. Adding it all up, it takes an average of 21 weeks for the entire process from referral to PAP therapy. When we look at the survey responses from the OB community, there were 58 respondents, 88% reported that they do not routinely screen for OSA in their patients who are pregnant or planning to be pregnant. 83% would be interested in training or education on OSA in pregnancy. Figure 2 shows there's variability in what practitioners use to screen for OSA, with snoring and BMI being the most commonly used. Figure 3 shows the self-reported barriers to screening. The most popular responses were that there were a lack of training or a lack of time. The Swiss cheese model here summarizes the holes in the process from referral to PAP therapy. leading to the potential adverse outcomes of maternal and fetal complications from untreated OSA. And there are many areas of inefficiencies along the process, and focusing upstream on referrals will really be the highest yield, in our opinion. We conclude that one, referral rates are low. This leaves women untreated and at risk for pregnancy complications. Lack of training is the most frequently reported reason. The next step in our QI project is to design an educational program on screening and understanding the risk of OSA in pregnancy. Thank you.
Thank you, Dr. Chu. That was very nicely articulated. You mentioned a next step being educational programs, but I'm wondering if there are some concrete recommendations that could be given to sleep centers to improve the timing of these patients to receiving treatment.
Yeah. So yeah, you know, in terms of the recommendations to sleep centers, I think right now in our own sleep center, I actually have a parallel project going on in intervention in which we have changed our referral boxes to allow providers to check a box if a patient is pregnant, and that really does alert our schedulers to prioritize their scheduling and get them in sooner, and that tag you know, will stay with the patient along the entire process. So, you know, the RTs will expedite their PAP acclimation, the scores will expedite their scoring, et cetera, et cetera.
Thank you. Wonderful. Thank you, Dr. Chu.
Thank you.
All right. Our next presenter is Dr. Eileen Condon, talking about sleep, family routines, and toxic stress among socially, economically marginalized families. Eileen?
Hi, everyone. Sorry, that title is a bit of a mouthful, I think. So this poster is describing the methods for my K99 Pathway to Independence Award. Results to share just yet, but I did want to share the overall concept behind the study. So the term toxic stress describes persistent elevation of the stress response system that occurs in response to chronic stressors like poverty, and over time causes a wear and tear on physiological systems in the body that ultimately leads to chronic disease and health inequities. My research interest is in understanding the intergenerational transmission of toxic stress and protective factors within families, especially families living with socioeconomic adversity, because this knowledge will help us develop more targeted and effective interventions. And so my hypothesis for this study is really around the concept of family routines. We know that consistent routines like eating dinner together every night are associated with better child outcomes. And we also know that sleep and circadian rhythm are very closely tied to the functioning of the stress response system. And so for this K99 study, I'm essentially testing the hypothesis that objective measures of sleep and rest activity patterns using actigraphy can be used as an indicator of how consistent or stable family routines are in the home, and that this consistency of family routines may be a mechanism underlying the intergenerational transmission of stress. So right now I am recruiting mothers with preschool-age children. I'm about halfway to my target sample size. And the goal of this phase is essentially to test the feasibility of my approach, having dyads wear actigraphy, actigraph watches, and to look at some preliminary effect sizes between my objective measures of family routines, some maternal self-report measures related to their parenting and their stress, and biomarkers of stress in the children. And I'll use this data to inform my fully powered ROO study, which is a more in-depth examination at biobehavioral mechanisms underlying the intergenerational transmission of toxic stress.
Thank you, Eileen. Could you talk a little bit about the challenges that you faced in COVID? So for those of you that don't know, a K99 ROO, it's like a 2-year K followed by a 3-year small RO1. So her goal for the K99 was to collect pilot data so that she can do a more fully powered study for the final 3 years of this project. And so COVID's been a real issue. How did you cope?
Yeah, so, coincidentally, I was all set and ready to go with data collection in March 2020. So that immediately sort of was, put on hold for quite a few months. And I was also planning to originally recruit from preschools, which the state of Connecticut has also not allowed because of the pandemic. And so just this past February, really, I got up and running with all of the approvals that I needed and switched to social media recruitment. And YCCI has been helping me with targeted Facebook ads and Instagram posts. So it's going okay. I'm having trouble reaching my target population. I really am interested in health equity, and so I want to really understand this phenomenon in socially and economically marginalized families. But for right now, because this is a feasibility study, I'm kind of taking anyone who volunteers, and then hopefully in the ROO phase, if things sort of are kind of a little bit more back to normal, I'll be able to get back into schools and recruit based on my original plan.
Teresa Ward wants to know, how did your families do with the protocol?
Fine. So I've had, I just enrolled my 14th family, and I would say just so far, all except for one family did well. One family, the child had some irritation from the wristband, and then they were taking it off for most of the days. And so that I think there was a little miscommunication, which I've learned a lot from in terms of, how to work with families. But for the most part, everyone else has done well. And we also, I should mention, switched to a socially distant approach. So the moms are doing all the self-report measures online. I drop off a kit to their doorstep so they can collect their own saliva and hair and blood pressure. And so that seems to be working so far okay too.
Thank you.
Thank you.
All right. Our next presenter is Dr. Samantha Connolly, talking about the prevalence and severity of sleep deficiency in adults with inflammatory bowel disease.
Thanks. So inflammatory bowel disease is a progressive autoimmune disease that it primarily includes Crohn's disease and ulcerative colitis. So people with IBD experience periods of active disease, and these are times where you can see overt GI inflammation on endoscopy, and they have rather severe GI symptoms. Then they also have periods of remission. In recent years, there's been quite a bit of attention on sleep deficiency in this population. However, there's no consensus about the prevalence and severity of sleep deficiency in this population. So in this study, we conducted a systematic review and meta-analysis to describe the prevalence and severity of sleep deficiency in people with active disease compared to remission, Crohn's disease compared to ulcerative colitis, and inflammatory bowel disease. So that includes both Crohn's disease and ulcerative colitis compared to healthy matched controls. We used the PRISM guidelines to conduct this review and meta-analysis. We searched multiple databases and used ARC to conduct the meta-analysis. So our final sample included 48 unique studies, which represented about 17,000 people with IBD and 900 healthy controls. Most studies use the Pittsburgh Sleep Quality Index to measure sleep, is over 75%. So that's what we used for our meta-analysis. The prevalence of self-reported sleep disturbance was higher with those with active disease at 71% than those in remission at 47%. We found no difference in sleep quality for those with ulcerative colitis compared to Crohn's disease. And we did find that about double the amount of people with inflammatory bowel disease at 46% had sleep disturbance compared to the healthy matched controls at 23%. We also found that those with active disease had significantly more severe sleep disturbance than those in remission, and that using objective measures of sleep, including polysomnography and actigraphy, so total sleep time, sleep efficiency, and wake after sleep onset were different than what is recommended for healthy adults. So overall, we found that people with inflammatory bowel disease do experience sleep deficiency, both during active disease and during remission, but it is worse during active disease. Because we only were able to meta-analyze the global Pittsburgh Sleep Quality Index. There's a lot of things we don't know about this population. And much research is needed to fully characterize sleep in this population, to fully understand the implications. Thanks.
Samantha, could you talk a little bit about where you might take this?
Yeah, so I'm
Next steps.
writing an R1 because there's so many questions about how sleep is actually associated with ongoing GI inflammation and the full characterizations of sleep. So using a full sleep health model to understand all of the dimensions of sleep instead of just global sleep quality, so that we can do an intervention that targets what's actually going on. So if we find they have a lot of insomnia, then we would do a CBTI intervention. If we find they have very short sleep, then we might do a sleep extension intervention. But because of how sleep was reported in this population, that's data we don't have right now.
Very good.
Thank you.
Thank you, Dr. Connolly. Our next study is entitled The Association Between Polysomnographic Phenotypes of Obstructive Sleep Apnea and Incident Type 2 Diabetes. And I believe Dr. Zinchuk will be standing in for Dr. Ding.
Yes, thank you, Klar. My name is Andres Zinchuk, and I am standing in for Dr. Priscilla Ding. The study that we did really tried to dissect a little bit whether there are differential risks for diabetes in patients with sleep apnea, depending on their physiology. And we know that sleep apnea is associated with increased risk of cardiovascular disease and type 2 diabetes. As we know that the apnea-hypopnea index might not be the best way to capture the physiologic risk of sleep apnea and its consequences for adverse outcomes. And in our prior work, we identified these 7 polysomnographic phenotypes or clusters that are associated with different physiological markers like different degrees of hypoxemia, periodic limb movements, events that occurred in REM versus non-REM sleep. And because pathways between risk of OSA and diabetes and risk of OSA and cardiovascular disease tend to be shared, we thought that perhaps these phenotypes would also have implications for incident diabetes. And so that was our hypothesis, is that these phenotypes or clusters will differentially predict risk of incident diabetes. And we did a secondary analysis of a retrospective cohort study within the VA population. We had about 840 veterans who had no diabetes at baseline and were followed for a median of 6 years to assess whether they developed diabetes. And at baseline, they also had full polysomnograms from which we were able to extract a variety of physiologic metrics, not just the AHI, but things ranging from measures of sleep architectures like sleep stages, continuity, arousals, and whether those were associated with leg movements or respiratory events. We looked at different measures of hypoxia, different measures of whether respiratory events were associated with obstruction or central events, whether we're in REM or non-REM, were they associated with consequences of hypoxia or just arousals. And we identified these 7 clusters, and those we called based on what were the general characteristics of them. And so we had a mild cluster, we had a cluster we called those periodic limb movements of sleep. We had a non-REM OSA and poor sleep cluster. We had a REM OSA and hypoxia cluster. And then we had 3 clusters that had very high frequency of events, and those we called hypopnea and hypoxia cluster, that most events were hypopneas. Those patients that had arousal and poor sleep, that most of their apneas had ended up with arousals rather than hypoxias. And then there was a cluster we called combined severe that was just profoundly abnormal in all categories and domains of sleep. And so when we looked at the distribution of incident diabetes in these clusters, we noticed that they were actually different. And that distribution of risk of incident diabetes, which is shown in figure 1, does not track with the AHI. And so the yellow lines, the bars are the AHI, and the blue bars are the risks of incident type 2 diabetes. And so what we see there is that in some clusters, the risk of incident diabetes is much higher than others, and that does not track with the AHI. So the AHI was not a great predictor. And so then we did adjusted analyses looking at hazard ratios for these different clusters. We found that there were 2 clusters in particular that were at highest risk of diabetes, and that was the periodic limits of sleep cluster, and then the hypopnea hypoxia cluster. And that risk was pretty significant. So it was over 2-fold in the PLM cluster and over 3-fold in hypoxia cluster. And what's notable is that, you think that maybe it's just the hypoxia that's driving it, and it actually might not be, because the combined severe and the REM hypoxia clusters had basically the same amount of hypoxia, but they were not at risk. And so there's something about having hypoxia that occurs with minimal upper air obstruction, such as hypopnea versus apnea, that makes the difference here. And so in conclusion, there are different rates of incident diabetes among these different polysomnographic clusters. The 2 clusters that seem to be most at risk were the ones with increased limb movements, even though they would be sort of generally categorized as mild OSA. And then the hypopnea-hypoxia cluster. And these clusters do add value to predicting risk of diabetes to sort of our traditional risk factors, such as age, sex, BMI changes, and so forth. And I'll be happy to take any questions at this time. Thanks.
Thank you, Dr. Zenchuk. I think the observation that PLMs, in addition to some of these hypoxia groups, is interesting. And what do you think might be on the mechanisms by which PLMs might heighten the risk of type 2 diabetes?
Yeah, no, I think that's a great question. PLMs are associated with autonomic discharges, so sympathetic to parasympathetic balance is very different in people who have PLMs versus those who do not. So there's sympathetic overdrive. The heart rate response to arousal tends to be higher in those people who have PLM arousals. And we know from prior literature that PLMs are in fact associated with incident hypertension. And so my suspicion is that it's that increased sympathetic tone chronically that leads to higher risk of diabetes. Now, the question is it just the legs, or is it the legs in people with OSA? And I think that's a critical question that still needs to be answered. Because if it's just the limb movements, then we have to focus on attenuating the sympathetic discharges and preventing limb movements in the first place. But if it's really OSA as a combination with PLMs, if there's a true interaction, then we have to address both entities together, even though OSA in these patients tend to be on the milder side.
Thank you very much, Dr. Zenchuk.
Thank you.
Our next poster is entitled Sleep and Bipolar Disorder Outpatients with Chronic Insomnia. And this is from an outside group. And I'm not sure if they are online.
Yes, I'm here.
Wonderful. Is this Dr. Dixon?
Yes, Bonnie
Please,
Dixon.
please go right ahead.
All right. Hi, everyone. Thanks for the opportunity to participate in this symposium. I do have my video on. Can you see me? Well, anyway, you can hear me, so I'll go ahead.
We hear you loud and clear.
So chronic insomnia is a common clinical complaint in bipolar disorder patients, and sleep management is especially important in the context of bipolar disorder because inadequate sleep can induce or exacerbate mania. So in this poster, my co-authors and I document the characteristics of chronic insomnia in a group of bipolar disorder patients and compare subjectively reported sleep quality in matched bipolar patients with and without chronic insomnia. 44 bipolar disorder outpatients participated in the study, 22 with chronic insomnia treated with daily hypnotic medications, and 22 non-insomniacs who were pair matched to the insomniacs based on age and gender. The insomniacs completed a questionnaire about the characteristics and time course of their insomnia, and all of the patients completed a set of validated questionnaires about sleep quality and sleep disturbance. So the insomniacs reported a mean age of insomnia onset of 23 years old and mean insomnia duration of 22 years. They reported having insomnia an average of 77% of the time, and on a 10-point scale with 0 meaning none and 10 meaning greatest, they rated the impact of their insomnia on their quality of life a 7.2, and they rated their satisfaction with their hypnotic medication an average of 7.3. And on the validated sleep questionnaires, the insomniacs scored much worse than their matched non-insomniacs on global measures of sleep quality and sleep disturbance. And the specific sleep problem that was most increased in the insomniacs compared to the non-insomniacs was the frequency of early morning awakenings. So these findings show that despite taking daily hypnotic medications that they find quite helpful, bipolar disorder patients with chronic insomnia still report notably greater sleep difficulties on questionnaires than comparable non-insomniac patients, and their sleep difficulties are long-term, frequent, and cause substantial impacts on quality of life. So more research is needed to identify contributing factors to the insomnia in bipolar disorder and develop more effective treatments.
Thank you, Dr. Dixon. That's very interesting work. I was wondering how, given that I think all of one group of your chronic or the chronic insomnia group were on a daily hypnotic medication, how did you deal with that analytically? And could this actually be an underestimate of the differences because of that therapy?
Yeah, I think undoubtedly it is an underestimate of their sleep difficulties, because this compares the insomniacs while they were treated with hypnotics to the non-insomniacs without any sleep treatment, obviously. This was just a preliminary clinical study, but I do think it makes an important point that the hypnotic medications were only partially effective for treating the sleep problems. The insomniacs still had considerable problems with their sleep, even with hypnotic medication.
Excellent. Thank you very much for sharing that work. And I believe you have another poster as well.
Yes, also from the same study. This poster is about factors that are associated with chronic insomnia in bipolar disorder. So as discussed in the previous poster, chronic insomnia is a major problem for many bipolar disorder patients, but its causal mechanisms and secondary effects remain poorly understood. So this exploratory matched case control study also aimed to identify factors associated with chronic insomnia in bipolar disorder patients. So as before, 44 bipolar disorder patients participated in the study, 22 with chronic insomnia and 22 non-insomniacs, pair matched to the insomniacs based on age and gender. We collected clinical, biological, and psychosocial data on all the patients from their medical records, biological samples, and questionnaires, and we compared the insomniacs to their matched non-insomniacs on 95 variables using univariate conditional logistic regressions. And here we report the variables that were most robustly associated with insomnia, with a p-value less than 0.05 and an odds ratio more extreme than 3 in order of decreasing odds ratios. So among the bipolar disorder patients, having insomnia was predicted by taking daytime anxiety medication, elevated fasting glucose, a family history of insomnia, low waking cortisol, the TERT gene A allele, a flatter diurnal cortisol slope, high TNF-alpha, high IL-8, and nighttime rumination. So some of these findings are consistent with known associations with insomnia, while others suggest novel associations that could be specific to insomnia in bipolar disorder. So further research, especially with larger samples, will be needed to confirm these novel associations and to elucidate the roles of factors such as the TERT A allele, low waking cortisol, elevated fasting glucose, and high TNF-alpha in insomnia in bipolar disorder.
Thank you very much for taking the time to join us today and share this work. I was wondering if you could, it looks like you did some additional analysis related to cortisol. I was wondering if you could comment on that.
Sure, yeah, you can see the graph in the upper right-hand corner showing the diurnal rhythm of cortisol in both groups, the insomniacs and the pair-matched non-insomniacs, at waking, half an hour after waking, and at bedtime. And you can see that the insomniacs had a flatter diurnal cortisol rhythm, primarily because the morning levels of cortisol were not as high as in the non-insomniac patients. We just know that this is an association. We can't determine whether it's cause or effect. with this type of a study design, but one can speculate that it may represent just a diminished circadian rhythm, perhaps, in the insomniac patients.
Right. And the TERT genotype is specific to bipolar disorder?
No, this is a gene that's of interest in the general population as well. It codes for telomerase reverse transcriptase, which is a catalytic subunit of the enzyme telomerase, which lengthens the telomeres, which are the caps on the ends of the chromosomes. And it's thought to be related to cellular aging. So I believe this is the first finding of a relationship between this genotype and sleep, but there is some existing evidence of a relationship to mood with this genotype.
Very good. Thank you very much for sharing your work.
Thank you.
All right. Our next poster is entitled Using Respiratory Volume Monitoring to Identify Respiratory Compromise in High Risk Obstetric Patients. Is Dr. Garay on the line?
Yes, I'm here. Thank you.
Oh, wonderful. Good.
And thank you for the opportunity to join your group here. So yes, my group did a formal comparison of true alarm rates for 3 devices, which show between SAT and capnography, which showed that there was a statistical difference between respiratory volume monitoring. The true alarm rates for SATs were approximately 1/3 that of the respiratory volume monitoring, while the true alarms for capnography were approximately 1/4 that. So just kind of to frame it all together, the main findings in the prospective observational study for comparing respiratory volume monitoring, capnography, and pulse oximetry is that 1/3 of the patients that experienced respiratory depression and that there was an overwhelmingly high number of false alarms triggered by SAT and capnography. Our study of high-risk women supported previous high-risk, actually postpartum women, supported the previous results that highlighted that higher incidence of obstructive inspiratory respiratory depression after neuroaxial anesthesia than less than 1%, of which is often cited. A similar designed study showed that 17.8% incidence of obstructive inspiratory respiratory depression when utilizing intrathecal morphine. Doses were equivalent in both studies. And the difference of this incidence, the OIRD, between the 2 aforementioned studies pointed out towards could be pointed out towards dose dependency. And the difference could be in the lipophilicity of drugs, or simply the higher threshold for end-tidal CO2 selected in a different study. Our study did demonstrate that most commonly used monitors, like SAT monitors in our institution, had a startlingly high rate of false alarms when utilized continuously. And during the study hours, false alarm rates were triggered every 12 minutes. This overwhelming number of alarms triggered by the SAT monitor was also in agreement with other studies, which led to another finding of just basic common alarm fatigue. In one of the studies, SAT monitorings of less than 95% were most commonly found to be abnormal readings that were triggered every 10 to 30 minutes, depending on the filtering criteria that they utilized in the mechanism, in the machine. And the high incidence of false positive alarms could lead to, again, like I mentioned, alarm fatigue. Besides the pulse ox, there's a surrogate of ventilation alarm, and the alarm is delayed response and hypoventilation. These findings suggest that there's more need for a more sensitive and a better surrogate to ventilation to detect respiratory depression after intrathecal morphine in our postpartum patients. Capnography offered, what we also found was that capnography offered a more sensitive and direct measurement of respiratory depression when compared to SAT, as it measures ventilation rather than oxygenation. In our study, the capnograph had a high incidence of false alarms and the least amount of total monitored hours. Contributing factors to that, we found these high false alarm rates in properly placed nasal cannulas, nasal obstruction, or people who just mouth breathe. The respiratory volume monitor has been shown to capture real-time changes in ventilation and respiratory rate, and it has validated against the use of spirometry and ventilators. In our study, the monitor had the highest number of monitored hours and the lowest false alarm rates. When an alarm was triggered by the respiratory volume monitor, there were 3 to 4 times more likely to be true alarms when compared to the SAT or the capnography, respectively. These findings suggest that there is a better sensitivity to detect the obstructive inspiratory respiratory depression and patients' acceptance of this. Our findings also are in agreement with the excellent correlation between respiratory volume monitors and we measured minute ventilation, tidal volume, and respiratory rate, and compared the ventilator volumes in the obese surgical cohort. By decreasing the number of false alarms, the respiratory volume monitor may also aid with predicting patients at risk for obstructive inspiratory respiratory depression. And that was demonstrated in a few studies as well. And just in closing, the American Patient Safety Foundation recommends continuous oxygenation and ventilation monitoring for all patients receiving neuroaxial and parenteral opioids. In addition, they recommend focusing on prevention rather than detection. Our current monitoring technology is not attuned to the task of prevention. Pulse ox in conjunction with a every 1 to 2 hour nursing assessment are probably the most commonly utilized in most institutions techniques with our postpartum wards. Regarding nursing intermittent monitoring, the anesthesia closed claim database showed that respiratory events transpired within 15 minutes, 1 hour, and 2 hours from the last nursing assessment in a 15%, 31%, and 42% of the cases respectively. Likewise, a meta-analysis showed a 15 times higher likelihood of recognizing desaturation, which would be a SAT less than 90, when continuous pulse ox was used, when compared to nursing assessment, and nursing assessment missed 90% of the events for at least 1 hour. On the other hand, an increase in monitoring may result in alarm fatigue, and this anxiety in the postpartum ward, and this would cause anxiety on the postpartum ward. When exposed to high incidence of non-actionable alarms, alarm fatigue could set in and result in response delays, future actionable alarms, and result in suboptimal patient care. Besides, false alarms may result in distraction that could lead to medical errors. Thank you.
That was very interesting work, and probably has application, to other postoperative populations of patients besides high-risk obstetric patients. Those are very interesting findings. Thank you very much for sharing your data.
Thank you.
All right, moving along here. Our next presenter is Dr. Jacqueline Geer, who will be talking about obstructive sleep apnea as a risk factor for intracerebral hemorrhage.
Hi, can you all hear me? I'm in a clinic room. Okay, perfect.
Yes.
Just by way of background, as we all know, obstructive sleep apnea is very common and treatable, and it's also a known risk factor for ischemic stroke. So surprisingly, there's very little work that's been done in the realm of hemorrhagic stroke and OSA, and it hasn't really been determined before whether OSA poses increased risk there. There have been some case reports that are suggestive. So our group sought to look into the question of whether or not OSA is a risk factor for the development of spontaneous intracerebral hemorrhage, which is a deadly form of hemorrhagic stroke that has similar risk factors to ischemic stroke. So we used a large case-controlled data set with some prospective component to it called the ERIC data set to analyze this question. And Eric didn't have polysomnography on the participants, but they did have a Berlin questionnaire completed at the time of enrollment, which was right in the acute setting of intracerebral hemorrhage. And there was also a Berlin questionnaire performed on all controls as well. So we basically decided that since the questionnaire was administered right at the time of admission, that it was representative of their pre-stroke OSA risk. And when patients couldn't fill out their own questionnaire due to illness, a close proxy did it for them. So as far as our results, we had access to 3,000 cases of non-traumatic ICH and 3,000 balanced controls. The ascertainment was fantastic. It was 96.5% completed the Berlin questionnaire. And we found that 71% of ICH cases had high risk of obstructive sleep apnea by the Berlin questionnaire, and only 52% of controls did. So in other words, the odds ratio was 2.28. And when we adjusted for confounders, the finding remains significant, as you can see. So the table that I included in the poster here shows relevant demographic and medical characteristics of the patients with low versus high likelihood of obstructive sleep apnea by their Berlin score. And those with high risk scores had much higher rates of the cardiovascular comorbidities that we would expect, as well as snoring, and they were more likely to be men. So in conclusion, we found that obstructive sleep apnea is prevalent in ICH and appears to be a risk factor. Clearly, more studies need to be done in this area, particularly with a better measure of OSA, such as polysomnography, rather than the Berlin questionnaire, which is what we were able to use for this one. In addition, we need to better understand the role of OSA in ICH pathogenesis, and then also it begs the question of the role of CPAP in both ICH outcomes as well as possibly prevention. So we actually had our work published very recently in Stroke. And so I put the citation in there if anyone's interested in reading more about it. So thank you, and I'm happy to take questions.
Thank you, Dr. Geer. Can you tell us about what your next steps are in this line of investigation?
Yeah, so basically the question of how to sort of the balance between performing, sort of the gold standard polysomnography up against the fact that this is a relatively rare disease is one that we've sort of toyed with. And so the next step will be actually doing some prospective work with polysomnography in the acute setting, patients in the neuro ICU who come in with ICH, and try to at least demonstrate feasibility that we can perform polysomnogram on these patients in the acute setting. And then hopefully that will lend itself to a larger project later on.
Thank you very much, Dr. Geer. All right. Our next presenter is Dr. Allison Moriarty-Daly, entitled Something Has to Give, an urban community engaged study of adolescent sleep.
Hi there. I think my video stopped by the host, so I can't turn it on. So I don't know if Lorena can help if you need me to. I just wanted to provide a little bit of background. Sleep is critical to adolescent health, daily function, and school performance. Yet 70% of adolescents do not get the recommended amount of nighttime sleep. Few studies have looked at sleep among adolescents attending school in an urban community. So the aim of our community engaged focus group study was to explore the multi-level influences on adolescent sleep health and behavior from the perspective of adolescents, parents, and school personnel living and or working in an urban community. We used a community engaged research model, which included a community advisory board with key stakeholders. The CAB, which we call them, assisted with recruitment, identifying focus group questions, interpretation of results, and next steps. Study participants were members of the community and had contacts with adolescents at home, school, or work, were English speaking, and were willing to participate, of course. 7 focus groups were ultimately conducted over about 7 months and all pre-COVID. They included 46 participants. 3 groups included teens, 2 were conducted with parents, and 1 included nurse practitioners and nurses, as well as 1 group that had teachers and social workers included. Half of the sample were teens who were in middle school through college freshmen. The majority of the sample were female. The teens identified themselves as African American and Latinx. And school personnel had a mean of 12.7 years working with adolescents. The focus groups were auto-recorded, transcribed, validated, and then coded in Atlas and analyzing using content analysis. So our results, we found 5 themes with corresponding sub-themes, and an overarching theme emerged from the data. The model that's presented here was developed to explain the data. Around the outside of the model represents the factors that influenced adolescent sleep. And these included sleep knowledge and beliefs, sleep habits, homework, packed schedules of the teens, the overall environment, family responsibilities, as well as mental health. The themes related to the consequences of inadequate sleep focused on overall health, mood, and school, and these are located in the center of the model. Exhaustion was found to be an overarching theme, and we defined it as drained of one's physical and mental resources, very tired or completely used up. Symptoms of exhaustion were apparent in this study and included things like chronic tiredness or sleepiness, headaches, impaired decision-making and judgment, and also moodiness. Finally, participants offered solutions and ideas to address adolescent sleep. Phone use was identified as a factor to change. However, participants recognized phones as an important aspect of teen life, not only for socializing, but they were also necessary for school. Many of the teens reported that they completed their homework on their phone because they did not have access to the internet. Sleep education was suggested as an important and missing. Most of the teens did not have health classes. A teen eloquently pointed out, quote, "I think education is a big thing. A lot of us just don't know," end quote, and suggested it be included in school as part of a comprehensive health education class. Finally, suggestions related to school included later start times, decreasing the number of credits that were required, decreasing homework amounts, and allowing upperclassmen to leave early so they could complete college applications, work, and do homework. In conclusion, this study found that adequate sleep was an issue for teens in the study and was influenced by a variety of factors. Older teens had additional factors like earlier school start times, college preparation, work, activities, socializing with peers, as well as family responsibility that contributed significantly to decreased nighttime sleep. Teens were exhausted, and this was found to negatively impact their health, their mood, and their school performance. We hope that this study will provide the initial steps to build a customized intervention to meet the needs of adolescents within our community. And we recognize that this intervention needs to focus on sleep education, phone use, balancing schedule demands, and working with schools to evaluate factors that contribute to decreased sleep among teens. And I'd just like to thank the CAB as well as the participants and the Yale School of Nursing for funding.
Thank you very much, Dr. Daly. Nancy, do you have any comments?
So I think, Allison, I think it would be helpful for us to sort of think about where we go with this. I think, nationwide, one of the large conversation in Connecticut and nationwide is about changing school start times. But I think our data are pretty clear that it's more than about school start times. And I wondered what your comments, and for those of you that don't know, Allison is a nurse practitioner in Career High School in this school-based clinic and sees these kids all the time, and we're falling asleep. And so what are your thoughts about next steps for research, but also regarding your practice?
So, it's important to kind of put this in context. This study actually was really born out of a conversation Nancy and I had at a faculty meeting about what I was seeing clinically in the school-based health centers and the impact of lack of sleep on kids. So one thing we did find from the data, which I think is really interesting, is that these problems with sleep and increased naps and less nighttime sleep and effects in mood all seem to really coincide with a change from middle school to high school. and that earlier start time. Many of the kids in this study, I would also have to, preface it by saying that they travel a long distance to get to school. So they're no longer kind of in their neighborhood. So they have to kind of get up much earlier than they did previously. And then there's just a lot of other competing demands on their time. So sleep really gets put to the bottom of priorities and only happens afterwards. So I think the important next steps are to really inform teenagers so they can make appropriate decisions in a way that they will be responsive, so that they can kind of take control a little bit more of this aspect of their health. So I think that's an important kind of next part that we need to think about and figure out what to do next. I think school-based clinics can provide, a wonderful service to them. We're kind of integrated within the school. And I think it's an important next step to kind of really consider in this.
Thank you, Dr. Daly.
There's one more question in the chat. How
Oh, sorry.
transferable, I'm sorry, I muted myself. This is hard going back and forth. How transferable do you think these results are to rural areas? Are the unique aspects of living in an urban environment that influence the responses?
So I do, I think this was really customized to our community, and it, by who we contacted to be in the study and the results. I do think that there are some aspects that may be transferable to urban communities. I mean, I think the one thing that we found with the phones is that everybody was pointing it to them as it being, the key to all of this. But our kids were really using them for all aspects of their life. This wasn't something that they could just easily give up. I mean, they were turning in homework on their phones, writing papers, keeping in touch with teachers. So it wasn't just those social aspects. And I would suspect in rural communities that internet access may also be a similar issue related to this, as well as socializing. So does that help?
That's great. Thank you.
Yep.
All right. I think some of the posters were slightly out of order, but I believe we have them all included. So we'll keep moving forward. The next poster is entitled The Impact and Exposure of COVID-19 on Early Childhood Sleep. Dr. Ordway, are you presenting?
I am actually. She's presenting the next one, though.
Oh, okay, great.
So hi, my name is Alex Malford. I'm going to tell you about part of our research project entitled Impact and Exposure of COVID-19 on Early Childhood Sleep in a Socioeconomically Marginalized Community. The COVID-19 pandemic has disproportionately affected marginalized communities, further highlighting the longstanding health inequities that exist in these communities. Understanding ways to understand and mitigate downstream effects of the pandemic in early childhood is a critical public health concern. Initial reports on the effect of the pandemic on children's sleep has been mixed and primarily reported among white children living in middle-income families. Our study aims to examine the association between the COVID-19 pandemic and sleep among children living with socioeconomic adversity. This presentation is a report of our preliminary findings from a cohort of a larger follow-up study on families who completed a longitudinal study conducted from 2015 to 2019. Megan Panera will present preliminary objective findings from Metigraphy following the next presentation. Our preliminary findings showed that the higher COVID impact was significantly associated with less total nighttime sleep. Additionally, compared to pre-COVID, there was a trend indicating later bedtimes during the pandemic. We plan to further examine this trend when the data collection is complete. In the meantime, this trend may be clinically meaningful and something for pediatric providers to target during their visits with families. These findings are based on parent-reported sleep data, and planned analysis include examining these relationships with objective sleep data. Furthermore, we've also repeated the stress biomarker data and parent-reported child behavior with the child behavior checklist. With the additional data gathered, we plan to further examine how children's sleep has been impacted by the COVID-19 pandemic. And so I can take any questions if there are any.
Nancy, do you have any comments?
So talk to us a little bit about what's the next. So you're going to finish this study, and so how might we use these data to think about, hopefully the pandemic will be gone. We may have another pandemic, and so how will this inform our future practice?
So the more we know about sleep in this sense, the better we can help do active intervention before, at the beginning of a next pandemic. Okay, we know these factors are impacting children's sleep negatively. Here's what we can do to help the families prevent these impacts, and also for right now, hopefully help families make positive changes to help their children get better sleep right now.
Did you collect some data on what was actually going on with the family? Things like there were people that were out of work, obviously, family members who were ill. Did you look at the factors that might have an impact on these sleep patterns?
Yes, so that was all collected as part of the COVID-19 exposure and family impact survey. It takes into consideration all of those, how families were exposed to COVID and how it impacted them. So, some families had no exposure and no impact, and some families, even though they're very exposed, had little impact, but some, even with little exposure, found themselves very impacted by these changes, even if they only had 1 or 2 levels of exposure. So it's definitely been interesting looking at the data and seeing how it's all coming together.
I think I've seen the term coronasomnia put in the literature. Thank you very much for sharing that, Alex. Okay, circling back to Dr. Mansour and staying on the theme of sleep and COVID-19, Dr. Mansour's project is entitled Sleep Apnea Severity and COVID-19 Hospitalization Outcomes. Sam?
Thank you, Dr. Yaggi. So I'll be giving an overview of our work, sleep apnea severity and COVID-19 hospitalization outcomes. Sleep apnea is a very common disorder that shares a lot of the comorbidities that are now considered as risk factors for worse COVID-19 outcomes. Sleep apnea also results in chronic inflammation, increased leptin resistance, and reduced nitric oxide. All of this makes an association between sleep apnea and worse COVID-19 outcomes seems plausible. The aim of our study was to investigate such an association. And for that purpose, we did a retrospective chart review of patients who were admitted with COVID-19 to the Yale hospitals who had an ICD medical diagnosis of sleep apnea. We then looked into the charts of these patients and grouped them based on their AHI severity from sleep studies that were on their records. And the baseline characteristics for the 3 groups, mild, moderate, and severe sleep apnea, are summarized in Table 1. For those 230 patients, we looked at mortality, inpatient mortality, and we found out that the severe sleep apnea group had the highest rate of mortality of 18% when compared to moderate and mild disease. However, that difference did not reach statistical significance. Doing a regression analysis for a composite outcome, which was inpatient mortality or critical illness from COVID defined by intubation or the need for NIV or high flow oxygen support, did not show a significant difference between the mild and severe OSA groups. Multivariate analysis for other variables such as gender, BMI, comorbidities, hypoxemic burden from the sleep studies did not also show a significant association for that composite outcome. Age did show a mild but statistically significant association with worse outcomes similar to the general population. And what was interesting was that CPAP compliance did seem to have a protective trend toward an association with better outcomes in terms of death and critical COVID. In conclusion, our data showed that worsening sleep apnea severity was not associated with an increased risk of mortality or critical illness from COVID. Increasing age did have an association with worse outcomes, and CPAP compliance appeared to have a protective trend. Thank you, and I'll take any questions if there's any.
Thank you, Dr. Mansour. That's very interesting, particularly the finding that CPAP compliance may have a protective trend. And remind me that the CPAP adherence was pre or post hospitalization or during the hospitalization?
It was pre-hospitalization. So we checked the chart for 1 year prior to hospitalization, and either we confirmed compliance through a PAP download or a visit to a pulmonologist or a sleep doctor who in his chart mentioned that the patient is using CPAP at home.
Great. And so I think a concern on the sort of observational studies in general in the field of sleep apnea and health outcomes that have looked at treatment efficacy is that adherence to CPAP therapy may be a marker for example, adherence to other medical co-therapy leading healthier lifestyles. Do you think that is what is going on here, or do you think there is more of a causal relationship between CPAP adherence? And
definitely. You're definitely right. We postulated a few ideas. First, maybe these patients have better access to care, and maybe that's why they did better. But also, we know that CPAP improves stuff like increases nitric oxide production, decreases leptin resistance, increases posterior airway diameter. So there are some hypothetical benefits for CPAP users that may protect them from COVID-19 on the long run. Again, this is a small study. This is an interim analysis. We're hoping for a second freeze and data analysis after the second spike of COVID. But it was an interesting finding for us to look into. And I think some people from Harvard found also a similar protective trend in their work.
Interesting. Thank you, Dr. Mansour.
Thank you.
All right. Our next presenter, I believe, is Dr. Ordway this time. Monica, are you available?
Yep.
There we go.
Sorry about that.
Not at all.
I'm Monica Ordway. I'm an associate professor here at the School of Nursing, and I'm here to present work from my K-23 funded study with Drs. Nancy Redeker and Lois Sadler as my mentors. I worked on this work because of recognizing that sleep is essential to children's health and development. But as we've talked about, it's a very significant and I think unrecognized concern, with 25 to 40% of children under the age of 4 having sleep problems. And then moreover, an increasing amount of literature demonstrating that there are sleep health disparities that are beginning earlier and even down to infancy. And that these health concerns that are related to sleep health, like obesity, metabolic syndrome, cardiovascular disease, are also disproportionately affecting children of color and those who are economically marginalized. So we, interestingly, with the sleep health definition of pediatrics being published in June this year, it's ironic to really think about the fact that we haven't focused enough on sleep health as a protective factor in toxic stress and early experiences of adversity in children. So we designed a study that was prospective and longitudinal. We recruited 110 toddlers and caregiver dyads at 12 to 15 months of age in New Haven through community health centers and early Head Start programs, and then followed them again when they were 24 to 27 months of age. So today, just presenting the baseline findings. We included self-report caregiver report questionnaires on sleep and parenting stress and other psychosocial factors, and also sleep actigraphy, which I'm going to present today. We asked the families to have the children wear the sleep for the actigraphy for 9 nights and days. We had very good compliance, although with the COVID study, follow-up study that that both Alex presented and Megan will present next, we're showing a little bit lower compliance, but we did have great compliance in this initial longitudinal study. The families were all, if you look down on table 1, the income to needs was 0.8. So these families are all are living below the poverty level. A majority of them with a high school or GED education or less, primarily single and unemployed. The average age of the parent was 29, mostly mothers completed the study. And there was a distribution of race and ethnicity that we collected: 43% Black, 30% Hispanic, and 21% white. While 72% owned or rent their home, about 24 had lived in a shared housing, were homeless, or had temporary housing. The average age of the infants, toddlers that we're going to report on today is 13.9 months of age. And so what we found was looking at actigraphy, as you know, will give us many of the sleep health measures. And something that I'm visually seeing on the actigraphy I've been conducting this study since 2015. I started to also like to acknowledge YCCI for the KL2 funding initially, and really interested in variability in sleep. And so we used mean successive square differences in order to calculate variability. And so of the actigraphy data, what we found was that the race ethnicity differences were significant at bedtime and in variability at bedtime. So you can see that in these last two rows on table 2. And so then what we wanted to look at, of course, is to understand why that would be, being that sleep is not a biological, race and ethnicity is not a biological variable, but a social construct. What could be influencing these kind of differences at 12 months of age? So we looked at all of the SES variables that we collected on employment, marital status, housing, protective factors, and income to needs. And the significant race ethnicity differences remained. And just sort of to kind of depict some of the differences, this is the bedtime for recommended for this age group would be before 9 o'clock. So it was about 8:45 for white children, Hispanic a little after 10:05, and then after 10:15 p.m. for the Black children in the family. And really what has struck me is the variability. And so I was thinking about how to think about that. And I explained that, when you have this kind of variability, it's like a toddler sleeping in Connecticut one night and then Central Time the next night, and then Mountain Time for while Black and Hispanic children, it's over a 2-hour difference. But then that's a night to night difference over the 3 to 7 nights that we collected. So this addresses an important gap in pediatric research describing sleep characteristics in a cohort of racially, ethnically diverse toddlers living in economically marginalized communities and among toddlers who are also underreported in the literature. And the children overall were not meeting the recommended sleep recommendations and had very high night-to-night variability. And we're very concerned about what does that mean in early brain child development and early brain development when we know that the brain sensitivity for the first 3 years is so critical and highly sensitive, and the connection between sleep and brain is so more to be done with that. So thank you for your time.
Thank you, Dr. Ordway. Nancy, do you have a comment?
Would you share a bit about what your new R34, just a sentence or two about where we're going to take your K23 findings? And I think it fits nicely with what Teresa was talking about with the intervention development.
Yeah, thank you, Nancy. It absolutely does. So with an R21 that Nancy, Dr. Redeker and Lois Sadler had, I was privileged to be able to help to work on an intervention to actually, kind of doing this work. It's really about the so what, how can we make a difference? And I'm very passionate about the idea that sleep health, if we talk about sleep health promotion, that might be a way of reducing toxic stress. So really starting early in life. So we worked with the early Head Start communities in New Haven and with the YCCI Community Ambassadors Program, and we developed a sleep health intervention that is a multi-level intervention looking at working with the child care teachers. As Teresa was mentioning, so important when, especially in health disparities work, to be looking at multi-level interventions. So we'll be working with the teachers to then work with the parents and the child. And we have an individualized tailored intervention that we will be launching in September with some newly awarded R34 funds from the NIH. So I'm grateful to NINR for their ongoing support in this work.
Congratulations on getting that additional funding, Dr. Ordway. Thank you for sharing your data.
Thank you.
All right, we have a couple more. Megan Panair will be presenting associations between COVID-19 impact and pediatric sleep and socially, economically marginalized family. I think some of the actigraphy data, if I'm not mistaken.
Thank you. Alex and Monica actually gave a great intro to my poster in terms of the background and why we're doing this research. So I'll just kind of jump right into my objectives and my methods. So I was specifically interested in how that parent-reported COVID-19 impact that Alex was mentioning, and then the associated caregiver distress was associated with the children's objectively measured sleep through the actigraphy data. I also wanted to see if the sleep health differences between the race and ethnicity groups persisted into this time point of the longitudinal study. So as Monica mentioned, the compliance wasn't as good this time around. So these findings are based on, depending on which analysis I'm looking at, either 16 or 17 families that had more than 3 nights of scoreable actigraphy data. So this is preliminary, and hopefully we'll have some more significant, more families that were able to score by the end of the study. So we did see that there was an association between greater COVID-related caregiver distress and earlier bedtimes, which was interesting and definitely merits some further investigation about that association. And then we did see the stark differences in the total nighttime sleep and the bedtimes between white children, Black children, and Hispanic children in this cohort, such that the Black and Hispanic children had significantly less nighttime sleep and later bedtimes than white children. And then after I adjusted for COVID-19 impact, these racial and ethnic disparities persisted. However, looking at the interaction between COVID-19 impact and race or ethnicity, I did see that a negative COVID-19 impact was associated with earlier bedtimes in Hispanic families. So again, there's some maybe not as intuitive results that we're finding, and definitely merit some further investigations into our data. As I mentioned, these are preliminary findings, but they do suggest already that we're seeing the racial and ethnic differences in the pediatric sleep characteristics in this cohort of socioeconomically marginalized families. And we're also seeing some COVID-19 impact and caregiver distress being associated with the pediatric sleep. But as I mentioned, we definitely need more data to fully flesh out this relationship. And I'm happy to take any questions that anybody has.
Thank you very much, Megan. Nancy, do you have any comments?
Yeah, so thank you. I thought I was unmuted. Yeah, thank you. It followed nicely on the other related talks. But, you know, so race and ethnicity are in some ways are many are social constructs. And what are your thoughts about what might explain some of the differences? And, you know, this is work still underway. Monica and our group have been working on this for a while. But what are your thoughts about some of the differences that might explain some of what you're seeing? Is it work? Is it culture? Is it parenting? What are your thoughts about where we should go with this?
Yeah, it is definitely something that we are still exploring. And actually, we are looking at kind of environmental factors that might explain this relationship. We're looking at using GIS to explore spatial and environmental factors, like, you know, light in the, like amount of light in the neighborhood, different kind of spatial analyses like that. And we need to know, we want to know more about not self-reported data and more of the objectively measured data. So, and I think that can be pulled in using the GIS spatial analyses, looking at, as I mentioned, the light, noise, crime, and in the different areas to see if any of those factors can give us some more information.
Thank you. I wanted to point out, and you know, we've had several talks sort of in this direction, that the NIH is right now very interested in these sorts of social determinants things like neighborhood factors, that explain some of the health inequities that we're seeing, as we see inequity in sleep as we see inequity in other health problems. And so the work is very timely. Thank you.
Thank you. Great. Okay, we have another outside poster from Purdue University. Is Lindsay Rosa here?
Yes, it is. Yes.
Okay, great. Thank you for joining us.
Yes, nice to be with you all. I did a literature review, really, of a design study. So the data hasn't been collected yet, so it's in its very early stages. But I wanted to look at those struggling with opioid addiction, especially now happening with the pandemic, and helping users find relief during their withdrawal treatment. Some of our hypotheses, we contended that lavender aromatherapy will lower BP, heart rate, and improve sleep quality, as well as their self-care, and as well as serving as a way of prevention for use in the future. So having a relaxation during their inpatient stay will hopefully prevent relapse as well. It's used as a conjunctive therapy alongside pharmacotherapy, helping quality of care in the inpatient setting. We liked this treatment because it's low cost as well and can reach a larger population struggling with chronic pain and improving their sleep quality. As you can see here with our study design, we focused on around 80 participants would be ideal over a 2-week time period, using data collection from a self-reported sleep journal with the Pittsburgh Quality Sleep Index, as well as a morning insomnia questionnaire. And the actual intervention itself is a 5-minute shower with lavender aromatherapy liquid, as well as blood pressure taken before and after that treatment. So we're also looking at hydrotherapy as well. So water and lavender together. After the shower treatment, lavender essential oil would be rolled on, and as well as using a diffuser as patients fall asleep. The next day, you're going to record all of the data collected and report that as before and after they wake up. We really looked at using the resources at the Indiana University Ruth Lilly Medical Library. So shout out to those folks who helped us collect and look at all of the different interventions that exist out there in the existing data, and what's actually been proven with evidence. As you can see, the data there, all of those on the left there are studies that show decreased systolic blood pressure. So the data is there, we just haven't really collected it in real time quite yet. Anxiety reduced, pain decreased, or just a few of those things there. The data for hydrotherapy were fewer, but still evidence there, pain reduction, anxiety lowering, sleep improvement, and relaxation. And we think this really can have a cost-effective strategy for those improving the quality of life for those undergoing withdrawal. So any questions that you had would be appreciated.
Thank you, Lindsay, very much. We have a couple of studies going on at Yale right now looking at sleep deficiency among patients with opioid use disorder. And as we were getting ready for these studies, we had some preliminary data to suggest that the sleep in this population of patients is really disruptive. And I think looking into relaxation therapies or biofeedback mechanisms might hold some promise. So thank you very much for sharing your data with us.
Thank you.
All right. Our next poster is entitled Differences in Sleep Between Veterans with PTSD and Other Mental Health Conditions, looking at consecutive referrals from the sleep laboratory to a VA sleep clinic. Is Gia Santoro on?
No, she's not. This is Jason DeViva.
Jason, how are you?
I'm all right, Klar. How you doing?
Great. Thanks for joining us.
Oh, no problem. Thanks to the
Somebody has a lot of noise in the background.
I think that's probably me, so I will mute.
How are we sounding now? Okay,
Much
I'm just going to
better.
go. Oh, excellent, excellent. I'm just going to go ahead and talk. Again, my name is Jason DeViva. I'm a clinical psychologist here at the West Haven VA. I'm presenting for Gia Santoro, an APRN at the West Haven VA, who's also, I believe, teaching faculty in the Yale School of Nursing. Gia had clinical patients she could not reschedule. So Gia and I and our third co-author, Alyssa McCarthy, are all folks who have done our primary clinical work with patients with PTSD. And we are also all CBTI providers here at VA. And Alyssa and I are two of the VA's national master trainers for its dissemination of CBT for insomnia. So we're all very interested in the intersection between trauma and sleep apnea is a major part of that. Individuals diagnosed with PTSD are far more likely to be diagnosed with sleep apnea than individuals without PTSD. And as with many of the sleep and PTSD relationships, the mechanisms behind that are unclear. And there's theories that have the causality going in both directions. So we were curious and wanted to look at how often PTSD shows up in a VA sleep clinic. And also some of the proposed mechanisms for the relationship between PTSD and sleep apnea would indicate that we might see BMI differences or maybe differences in the rate of hypertension in individuals with PTSD and sleep apnea versus other individuals. So we looked at whether those things differed. We wanted the most naturalistic sample we could find, so we looked at 200 consecutive referrals for overnight in-lab polysomnograms. We didn't use take-home actigraphy. We didn't use split night studies because we wanted just a comparable data set for everybody. And then we also reviewed the medical record for demographics and for other medical variables. So we found that of those 200 consecutive referrals, which occurred over a 7-month period, 30% of the sample had PTSD, which is 2 to 3 times more than the general VA population. Another 40% had some other mental health diagnosis, and only 30-some-odd% did not have any kind of a mental health diagnosis. About half the sample had sleep apnea upon examination. Individuals with PTSD were no more likely to be diagnosed than individuals without. And this was a fairly medically complex sample. If you're thinking that veterans are an easy group, 60% of this sample was on at least one psychiatric medication. They averaged 2 psych meds. And over 80% of the sample was on at least one other kind of medication, and they averaged 4 other kinds of meds. The sample with the diagnosed with PTSD group did not differ on any sleep measure from either of the other 2 groups, either the no mental health group or the other mental health group. What's interesting is the PTSD group was younger by quite a few years. It was statistically significant, and it also had passed the eyeball test than the other groups. So these results told us first and foremost that PTSD and general mental health conditions are pretty common in a VA sleep clinic. And for some reason, individuals with PTSD are getting there earlier than other groups, possibly because they have earlier onset of sleep apnea, possibly because they have a greater level of clinical contacts and people are more likely to notice notice indicators of sleep apnea. There were no differences in hypertension or BMI. And it's very interesting. Physiological factors, things like upper airway musculature and such, probably account for much more variance. But still, there is that interesting big difference between folks with PTSD and folks who don't. So we took out of this the hope that there could be more collaboration between mental health and behavioral sleep medicine providers and VA sleep clinics, because PTSD and sleep apnea have this sort of mutual complicating factor for each other. And I think the more we collaborate, the better things will go. I hope that was fast enough, thanks to the 2 or 3 people that hung around this long to listen.
We have 34 people hanging around this long to listen.
Really?
Yes.
Thanks to all of you.
This very interesting, and I think there's what I'm struck by is the higher rates, and what do you think may explain sort of this connection between sleep disorder, breathing, sleep apnea, and PTSD? How does one affect the other?
Well, what's interesting is we know that looking just at sleep quality generally, we tend to assume that difficulty sleeping is a symptom or function or part of PTSD. When we look more broadly, difficulty sleeping actually puts people at risk for later development of PTSD, whether it's pre-trauma sleep or kind of peri-traumatic sleep. So I wonder if you know, if sleep apnea or whatever early proto sleep apnea there is at the time of trauma exposure actually puts people at greater risk of developing PTSD. But I do know that when you mess with sleep, you mess with everything. And we've done some nice ecological momentary assessment studies that show that we used to think that sleep in the day would predict worse sleep. PTSD symptoms in the day would predict worse sleep at night. Turns out it's the opposite. The worse you sleep on a given night, the more likely you are to have a spike in PTSD symptoms the next day. So I would think that sleep apnea contributes to that. So it's a very complicated interrelationship. And I think the more we look, maybe the more we'll find.
Yeah, I think that and some of the sympathetic activation that occurs probably is not beneficial to in sleep apnea to PTSD, etc. That's very interesting. Thank you for sharing your work, Jason.
Sure.
All right. Our last, but certainly not least speaker is Dr. Brian Wojcik. And Brian, I sympathize with you. We did go in alphabetical order. My last name begins with Y. I'm sorry we left you for last. I feel your pain, but please share the results.
Oh, no, it's been the story of my life, so it's no problem.
Always the last to the table.
Always the last one. No, so hey, my name's Brian. So I've worked with Dr. Yaggi and my other mentor, Dr. Nzuki. We did a secondary analysis of the DREAM cohort, and we were looking at incident diabetes. So our real aims in this cohort were to find out predictors, polysomnographic predictors of both incident diabetes and pre-diabetes, and then model for things that might confound those predictors. You know, the biggest concern we would have is BMI. So we'll talk about that in some detail. When we reviewed the record, you know, of the DREAM study, we managed to get 650 patients that initially had no diabetes. So that was defined as no medications, a fasting blood glucose less than 125, and an A1C of less than 6.5. So we kind of put together this initial population and then followed them over time and said which patients first developed diabetes and were there polysomnographic predictors of developing that diabetes. And we did the same thing for pre-diabetes. So and this is kind of our preliminary analysis, so there's still some work to be done, but we found that when we corrected for baseline BMI, age, race, gender, change in BMI over time, CPAP use, that what predicted incident diabetes were the respiratory arousal index, the total arousal index, hypoxemia, so a low, you know, T90, so less than 90, and mean nocturnal oxygen saturation was protective. So a higher mean nocturnal oxygen saturation was protective. And so I'll alert you to the actual raw numbers here. When we see 0.009, that means per event. So you had an increase of about, you would have an increase of about 1% per event. So although these numbers look very small, when we actually kind of think of them as per event, they actually mean something. When we did this for pre-diabetes, the data point that persisted was the mean nocturnal oxygen saturation. So and that might be just because we don't have enough data, but what we found most interesting was that, you know, AHI was not significant in either analysis. So this might be kind of a first step to thinking about that, you know, hypoxemia and arousal is really what might drive the association of metabolic dysfunction, more so than just the apnea-hypopnea index. And I think there's definitely more work to be done in that regard.
Thank you, Brian. It is interesting that some of these more direct measures physiology, arousal, hypoxemia may seem to have a stronger relationship with these outcomes, with these metabolic outcomes. And it will be interesting to see if there are consistent relationships with pre-diabetes. I think that would strengthen some of the causal pathway inferences that are being made in this field. Thank you very much for sharing your work. And that brings us to the end of the poster presentations. I'm going to stop the share, and we are running over time, but I wanted to just say a last word to thank Lorena Fonte for organizing this event. I think she did an incredible job of pulling this off virtually. And also our keynote speakers, Drs. Ward and Kuna, and all of our presenters of the posters. It is really exciting to hear about all the work that is going on inside the institution and outside as well from our keynote speakers. I also want to thank my co-chair, Dr. Redeker. It has been a pleasure collaborating with you over really the last decade and seeing this domain of research sort of grow over time. Nancy, did you want to say anything before we wrap up? I think you're muted.
Just to echo what you said, Klar, and we hope to see you all next year. And we hope it'll be face-to-face.
Yeah.
Thank you.
And food will be will return. Yeah. Exactly. Anyway, have a wonderful weekend, everyone. Thank you for joining us today. All the best.